Can I just again remind members that switch off mobile phones. Meetings are held in public session, and obviously mobiles and other devices will interfere with the recording. I have had apologies from Sam Gardner. Any other apologies? No. Okay, members, under chairperson's business, a number of items. I want to inform the committee that members and a number of members here visited the pavilions in Lisburn this morning as part of our review into supported living for older people. Also want to remind members that the committee had agreed to visit the Queen's Cancer Centre on Wednesday the 18th of June. The visit will start at 10:30 and transport can be arranged from here at 9:45. There's tabled pro formas indicating, please ask members to fill them out if you're available to attend and if you do require transport. Also want to raise the issue of the announcement yesterday by the Human Rights Commission of the intention to carry out an inquiry into emergency health care. Now, obviously, this is an important move and one that none of us should neglect or ignore. The inquiry will consider the human rights obligations in terms of the executive and other relevant public authorities, and will identify the extent to which the human rights of people seeking emergency care are respected, are protected and are fulfilled in practice. Obviously, this is an important move. It is a serious move, and it is one that I think, if it's done in a robust, professional manner, can effectively bring the appropriate measure of scrutiny that is required alongside our role as a committee. They have opened a confidential telephone line for patients and staff to be able to share their experiences, and they will be holding a number of public hearings in the autumn. Clearly, as I said, it is an important development in terms of the numerous problems that we're aware of and that are associated with A&E and that have come to light over the last months and years.
Chair, just on that, who initiated this action in relation to bringing the human rights people in here?
The Human Rights Commission themselves, under their own statutory legislation, can do that.
Was it your initiative that started? It was. I thought that by your approach the other day in the chamber. That confirms it, right? Thank you.
Okay. So clearly there's an ongoing review as well that RQIA are carrying out in relation to emergency services, specifically within the Belfast Trust. But again, that review was to be more regional than just Belfast. That's due to report to the Minister by the end of this month. So I'm just making members aware that that process is ongoing. We have now today received a letter from the Human Rights Commission, which is on the tables. They are asking to come to the committee to brief us on their work. I'm suggesting, members, that this is a hugely important piece of work. I'm sure you will agree, and that the committee should hear from the Commission at our soonest opportunity, which looks like the 18th of June. So I'm asking if members are in agreement that we proceed on that basis and invite the Human Rights Commission to attend the committee on the 18th of June.
Great.
Thank you. Item 3, members, is the draft minutes of the meeting on Wednesday the 28th of May. They are on page 6. I'm asking our members content with the minutes.
Great.
Thank you. And item 4 is the review of waiting times, the evidence session with the Department and Health and Social Care Board. There is a briefing paper from the committee clerk at page 12, a summary of the key issues that was raised in evidence sessions taken by the committee, which are at page 19. We've correspondence at pages 31 to 35, and the Hansards of the evidence sessions at pages 38 to 81. Okay, folks, you're very welcome, and we have, not in any particular order, we have Heather Stevens, Director of Service Delivery at the Department. Mr Chris Stewart, Director of Healthcare Transformation at the Department, Mr Eugene Mooney, Director of Information and Analysis at the Department, and Mr Dean Sullivan, Director of Commission and Health and Social Care Board. Just want to advise the witnesses that there's a number of key issues that the committee wishes to discuss today, obviously coming from our process around the inquiry. We want to work through each of those in turn, and we want to use the opportunity to understand, I suppose, what the Department and the Board's position is on these issues before we would be making any recommendations in our report. So we just would welcome that open and constructive debate. You know the formality in terms of today, so I understand that you're going to make an opening comment.
Yes, Chair. Thank you very much. We're very grateful, actually, for this opportunity to participate in the committee's review of waiting times and to build on the input that the Department provided to the committee back in January and February. We do know and appreciate that you've set out a number of areas you want to explore with us, so I will be very brief in these opening remarks. The need to improve access to health services and in particular to reduce waiting times is certainly a key priority for the Minister, and that has been pursued through setting standards and targets in successive commissioning plan directions. However, we in the Department fully accept that performance is not in many instances where it should be, although some progress has been made, and that is certainly the case compared to the position, say, 8 to 10 years ago. We also know that this is one of the most complex and challenging issues that we have to get to grips with, and that has in fact been a consistent message which has come through in these evidence sessions. It's a universal problem, and no one actually seems to have identified the magic bullet to fix it. Instead, we can see that different countries are approaching it in different ways, and so we are very keen to consider practices and learning experiences from those other countries or regions which have implemented different models to reduce elective waiting times. So we very much welcome the committee's thorough investigation of these issues, and we look forward to receiving your recommendations in due course. And we would welcome sight of any further evidence that is available on the efficiency and effectiveness of other approaches as we continue to seek to improve the patient care pathway and experience. We know that one such approach is to look at measuring the entire patient journey through a referral to treatment time. And this approach is being followed in a number of countries, for example, England and Denmark. But the key thing is that it is early days in terms of their implementation of that approach, and we're very keen to learn from that and to look at the experience elsewhere in order to inform whether the significant investment needed to pursue this approach in Northern Ireland is worthwhile, particularly in the prevailing financial climate that we find ourselves in. However, while we assess the merits of other approaches, our immediate focus continues to be on improving the waiting times for the individual elements of the patient pathway. So that's outpatient assessment, diagnostic tests and inpatient day case treatments. We're also in the process of developing in parallel other measures which are much more focused on the outcome and experiences of the patient, to help them make informed choices and to help address the issue that was identified by Professor Normand in his evidence, in that a lengthy waiting time may not necessarily mean that a patient is suffering a detriment. We also know that reducing waiting times is not fixed simply by focusing on elective care provision, because there are important interlinkages between other parts of the secondary care system, for example unscheduled care, as well as primary care. And so a whole system solution is required which looks at patient flow right across the piece. We do have robust information. The HSEB has carried out a demand capacity analysis across all of the secondary care specialties, so the board knows when demand exceeds the capacity of the trust to deliver. However, we also know, and the evidence sessions have again borne this out, that what is needed is not simply a supply-side solution, with additional capacity being brought in to reduce ever-growing waiting lists. We need to find ways to manage demand in the context of a demography which can only present an unsustainable increase in demand. So LGCs are already working on developing pathways to reduce pressure on secondary care services, and we're indeed starting to see some exciting new initiatives from GPs themselves in terms of federations or clusters of practices, maximising their own particular interests and areas of expertise in order to reduce the referral rates. So in summary, we know that we have a significant challenge to grapple with and that we have to tackle it in a number of ways, including managing demand, but also continuing to invest in capacity and making sure that we measure progress effectively, all whilst making sure that we keep the needs of the patient absolutely at the front and centre of this. So, Chair, that's all I wanted to say by way of preamble, and colleagues and I are happy to go through the issues that you've raised and to answer any questions.
Okay, thank you, Helen, for that. Just, I suppose, in terms of the issue of the referral to treatment time, and I suppose it's your view, and I'm thinking initially, that one of the pieces of information that we were discovering as we were going through the inquiry was that if there's only the stage of treatment targets, that there can be perverse incentives, if you like, for managers to often delay patients. Is that something that you would have a view to or a sense of?
Chair, if it meets with your approval, perhaps I could answer that, and in doing so expand a wee bit on some of the things that Heather has said. First of all, to answer that specific question that you put, I mean, I think we would recognise the potential within the system for those sorts of perverse incentives. I'm not aware, unless Dean is aware of anything different, of specific evidence of that happening within our system in Northern Ireland. Nevertheless, we recognise that the potential for it would be there. In overall terms, I think it's important to emphasise the Department's view on a referral to treatment target is that we think it's highly desirable for the range of reasons that have been given to the committee in recent weeks by the other witnesses who have come before you, because it would remove those perverse incentives, take them out of the picture completely. It would better reflect patient experience and what the patient is really interested in, which is the entire journey. And we think it would also reflect the clinical interests. Doctors and other clinicians are interested in the patient's entire experience. So we would have a much better target all round as and when we're ready to move to that. It would also ensure that we have a complete end-to-end focus on performance, and we'll be able to ensure that any hidden delays in the system are being identified and tackled. So for all of those reasons, we think a referral to treatment target would be a very good thing. It is, as you've heard from a number of witnesses in recent months, difficult to achieve, and there will be a number of challenges that we will have to overcome in moving to that form of target. And they fall, I think, into three broad groups: policy, resource and technical feasibility. And I should stress, this is not excuses for not doing it. We think all of these are capable of being overcome. In terms of policy, I think there's a number of key decisions that we would have to take. Firstly, how would we do it? As Heather said, this is still a relatively new approach. It's not particularly well established around the world. There is no single obvious best practice model that we could pick at the moment to follow. That doesn't mean we can't do it, it just means we've got a difficult choice to make up front. We also need to look at some more technical aspects of policy. What type of measure would we adopt? And again, you've heard from witnesses in recent months that there are several approaches you could take to this. You could have a snapshot of those who are waiting within the system at any given time, or you could base a measure on completed journeys, and there are advantages and disadvantages to both. If you measure completed journeys, then you know exactly what the experience has been for those patients and where the problems have been, if there have been. But that measure is retrospective, tells you what the system has done, not what the system is doing or is going to do. A snapshot of people waiting is more current, but isn't complete, because people are waiting. You haven't entirely bottomed out what their experience has been. So there's a choice to be made there. What type of measure, or perhaps both, would need to be included? Another key issue, I think, in policy terms at the system level for us, is that if we're going to use such a measure, not just to manage the performance of our own system day to day, week to week, month to month, but also to do a comparative analysis of how we're doing against other jurisdictions. Then I'm not saying we have to adopt the same measure as every other jurisdiction, but we have to understand and have a rich understanding of what the differences are so that we can make some comparisons. I think the second group of challenges relates to resources. And again, you've heard from witnesses that this is not something which is easy or quick to do. It would take a number of years of hard work to get in place, and investment perhaps running into millions of pounds to get it put in place. And of course, there's an opportunity cost there. Undoubtedly a very good thing to do, but while we were doing it, we'd have to divert some of our performance management resource away to develop that new approach. So there's a danger that our eye might be off the ball in terms of managing the system while we're developing the new target. And related to that, I think we do know, and we have heard from the Scottish and English experiences, that these sorts of developments, the introduction of these sorts of targets, need to be preceded by a focus on getting the performance and the measurement right in the individual stage targets that we currently have. There's a challenge for us in trying to do both of those things at once. The third set of challenges, I think, is around technical feasibility. We need to be certain that the information systems that we currently have are compatible with this sort of approach, that they're comprehensive, so that we are actually capturing all of the elements of a patient's journey that we need to do. And some development, obviously, of systems would be needed, and we need to think carefully about how we do that. To put it candidly, do we rip out and replace the existing systems, or do we try and overlay them with a new system that would sit on top and gradually replace the legacy systems underneath there? Key decision to be made there. Chair, you and the members, I'm afraid, will know of many examples in the public sector where the approach has been based on rip out and replace, and we haven't got it right. Information projects have gone over time and over budget. So I think there's a strong argument for trying to overlay a system on the existing systems and replace as they come to the end of their natural life. And a very good example, I think, of that is the electronic care record. That was the approach that was taken. We did not rip out and replace. The existing systems will reach the end of their natural life and will be replaced. And each time that happens, they're compatible with the overlying electronic care record system. All of those challenges to be overcome, Chair, and there's one final point that I think is worth making. When is the right time to introduce a referral to treatment target? And I think there's a strong argument for saying that the right time and the right context would be as part of a change to commissioning arrangements. Now, we currently commission not full patient journeys, let alone outcomes, but we commission episodes of treatment or stages of treatment. And I think success in this approach is much more likely if we can get those two things aligned, if we can move to new commissioning arrangements so that we're commissioning patient journeys, better still outcomes, and so that the currency that we use, both for commissioning and the measurement of performance, is the same. Chair, in summing up, again, may I emphasise, we don't offer those to you as a series of excuses for inaction, but simply a candid description of the things that we will need to do to put this sort of target in place.
Thank you, Chris, for that. Can I take it then, and I welcome the detailed response, but can I take it that when you say that referral to treatment as a system and as a process is highly desirable, that the Department are now committed to it in principle at least?
That will be a policy decision for the Minister, but I think in replying to the committee, the Minister has endorsed that line that is highly desirable. He will expect us to treat that as a priority. Okay,
and that is ultimately a shift, if you suppose, a welcome shift, but a shift nonetheless from I suppose, the engagements that we had before on the issue.
It's a shift in the sense that it represents the leading edge of best practice at the moment. Now, as we've said, it's not practice that is fully developed. I mean, we are watching developments in other places. Nevertheless, it's the direction of travel for those who are at the leading edge. If we want Northern Ireland to be at the leading edge, then that is the direction we will have to go. It is highly desirable, as I say, and this is not a cop-out. Policy decisions are for the Minister rather than us, but I think it is recognised that that is best practice.
Okay. And just to follow on from that, you had outlined, because I know in the response that we had from the Department, was talking about a move to RTT measurement would be both challenging, both financially and logistically, and you had outlined there in your comments around policy, resource and technical feasibility, and give us some details of that. But I suppose my question would be, are we about to move to a business case, or is there consideration of that in terms of feasibility and cost?
No, we're not at that point, Chair, and I would be misleading the committee if I gave you the impression that we were about to go to that point. There would be a great deal of work to be done.
Okay, but we would be moving in that direction of a consideration of
I think, as Heather said, we recognise that that's best practice, but we recognise that the committee is doing an important and serious examination of this area. And I think we would want to see what your recommendations and conclusions are before putting definitive advice to the Minister on that.
Okay.
And I think, as we said earlier, because the other countries who've gone down this route are at an early stage, we do want to monitor how they are progressing and learn from their mistakes, but also their good practice that they identify.
So there are engagements from the department with other countries, regions. Is that happening?
I think we're with the start now of that
Okay.
engagement, and certainly this review that the committee has undertaken has been enormously helpful in terms of identifying where we can usefully look.
Okay, glad to be of help.
Excuse me, Chair, if I may, just one other point that might be helpful. It's not totally new to us in Northern Ireland. We do have one pathway where we do measure from referral through to treatment, which is for cancer patients. So for patients referred urgently by their GP, there is a 62-day target that the Minister has set. That 95% of patients are required to commence treatment within that 62-day period. So I think that demonstrates for us all that it is feasible in principle, but I fully agree with what departmental colleagues have said, which is around the technical challenges and logistical challenges that would be around a big bang approach to introducing that more generally. But I suppose the cancer shows that there might be a possibility, subject to the view of the Minister and others, to incrementally move towards that. But the more fundamental issue would be around making sure that at least the individual stages of the pathway were broadly in the right sort of a place before moving to that. Otherwise, you would just be moving to a place of measuring differently something that wasn't what you wished it to be. Moving clearly to a total patient journey time wouldn't of itself fix underlying major difficulties at any individual point in that.
And I think some of that will come out around the discussion around targets in general and their enforcement. Roy?
Just delving in a little bit more about the cancer treatment system that you have. How long has it been running, and what has been your experience of it?
Mr. Beggs, the cancer target was introduced, the 62-day cancer target was introduced, as I recall, in 2007.
Your monitoring systems, what I'm interested in.
So the facility was in place to monitor that target in the 7-8 financial year, as I recall. I'm sure departmental colleagues can check that and confirm that to committee members after the meeting today. But since then, that has been in place. That was a target at the time that was in England, and an equivalent target was introduced within Northern Ireland. I understand England have reduced that to 85% rather than 95%. So for several years in relation to cancer, that has been in place.
Okay, so why could that software system not be extended to other departments?
I don't think Chris can speak for himself. It's less the software technicalities around some of all this. It's the sheer scale of things you are tracking. For the patients urgently referred with cancer who go on to require definitive treatment is a tiny subsection of the sort of numbers that we're talking about here in terms of the breadth of specialties and trusts and systems and so on. So all of that would be and could be teased out. The more fundamental issue for me is around the getting everything ready for the system to be introduced, rather than necessarily huge systems issues that Chris talked about. The electronic.
Why can it not be rolled out? It doesn't have to be big bang. Why can it not be simply adopted in another department, for instance, and widened?
Well, because the scale of things within cancer, where you're talking about patients in relatively small numbers each month, allows a different, more targeted approach than something in relation to elective care more generally, whereas we know we're talking about tens and hundreds of thousands of patients as opposed to dozens and hundreds of patients. So it's simply a scale thing. But you're right, the principles wouldn't necessarily be any different. It is, we are able to identify when an urgent referral has been made. We are able to identify all the bits in the pathway, including the complexities in cancer of patients perhaps being seen in the first instance in, say, Antrim. And then if it's particularly specialist care, they require like radiotherapy, the patient then being referred into Belfast. We're able to track the patient around the system in that way, but it's because the numbers of patients are literally not handfuls, slightly more than handfuls, but not in the thousands that we're talking about. But I'm sure you're right, the principles would be applicable.
I think just to add to that, I think it is an issue of scale. Once we reach the point where there is a software system in place that can pull out all of the various pieces of information and stitch them together, then yes, you can roll that out anywhere. I don't know, but I suspect in terms of the cancer target that there's an element of manual processing in that at the moment. Again, as you heard from, I think it was the Scottish experience, that's one way of starting, which is that you can have a largely manually driven process with people with the role of patient trackers, joining up the various pieces of information at the minute. Hugely labour intensive, would be a distraction of resources from, as Dean said, managing the bits of the system that we know aren't working well enough at the moment and where the real problems are. Could be done that way. Not a terribly efficient way of doing it, probably not a terribly effective way of doing it, and I think at the sort of scale where you were rolling out to the big numbers and say orthopaedics, probably not practicable at the moment.
Can you tell us something more about the current patient administration system? How old is it and what is its life expectancy?
I've looked at my colleagues on that. That's not something I would have detailed knowledge of personally.
I couldn't say in terms of years, but I know it's been raised by the committee in the past when we looked at outpatients, consultant cancelled outpatient appointments, and we were looking there to see whether, it could be revised. But the patient administration system is, it's a system that is common across the UK. It's not a question that it's not fit for purpose. It's fit for the purpose it was designed to do. In terms of introducing a referral to treatment time thing, there's a number of stages where we switch clocks on and off at the various stages. Some of it, colleagues have said about where some of those clocks start and stop. There are parts that we miss. We miss things about when the decision made to send the patient for a diagnostic test. It'll stop in terms of the time then taken to report that back, come back to the consultant to look at that, make a decision, then have a review appointment.
Why does it stop? Why does the clock stop?
Well, it's just that because there are different systems in place to record. We have different systems for inpatients, for outpatients, and for diagnostics. And one of the things that we seriously are looking at, if we have captured a number of the elements of the stages, and as we are now looking at this clinical community gateway, where we're looking to see if we can get most of the referrals that are coming from GPs through electronically, so we will know that they're all coming to the trust. We'll be able to capture how many are coming through there, and then at the other end of the stage. So we may still be able to get that time difference, but maybe not in the way our colleagues across the UK have.
Can I go back to my question? How old is the current system?
I don't know the exact date.
Can you come back to us with that?
I certainly will, yes.
And in terms of it, I recall when we were looking at missed appointments that there was difficulties in adopting new technology, automatic text messaging and this sort of thing. So what's the cost of those missed appointments, and would you accept that a new system might actually bring about a number of other benefits as well as actually capture the referral time to treatment?
I think there's no doubt that investment in improving the systems will bring all sorts of benefits such as those you've described. Again, I think on this, I'm afraid we will have to come back to you with the detail on the PAS system. I'm afraid none of us are familiar with that. But I think in terms of a strategy to achieve that, I go back to what I said earlier, I think the first decision we face is, do we rip out and replace, or do we adopt what instinctively I think would be the better approach, which is to look at things like PAS and look at what are its limitations, where is it falling down, what is its natural life cycle, and how close is it to that. And then in replacing it, underneath some sort of a portal or overlying system that would sit on top of that to ensure that its replacement has those features that you've talked about, like automatic text messaging, which simply wouldn't have been thought of when PAS was introduced, I would imagine, because that sort of technology didn't exist. That, I think, is, it's the very opposite of the Big Bang approach. It's graduated, it's incremental, which means that you don't realise all of the benefits for some years, but I think it's lower risk. And I think, as we've shown with the ECR success story, I think ultimately it's more likely to be successful.
From talking to your English colleagues who have the system, have you a ballpark figure of what it would cost here?
I'm not aware there's a reliable estimate for Northern Ireland.
Have you seriously looked at it if you haven't got a figure, even a guesstimate?
No, is a straightforward answer to that. I don't think there has been an estimate made.
I think, Chairperson, if it's helpful again, Mr Beggs referred to the issue of patients not attending appointments on the day of the appointment or cancelling on the day of the appointment. And having sat with a different hat on in front of this committee and other committees in the Assembly, we've been here 3 or 4 years ago, the typical DNA rate was around 11 or 12%. Against an English average at the time of about 10.5%, as I recall. The position in Northern Ireland now is materially different to that. The position last year in Northern Ireland was about 7.5% of patients didn't turn up for their appointment on their day. That's lower than the equivalent position for England. So I think there's always further opportunities through either, ideally through technology, but through other measures as well. I don't think that would be the only reason why you would introduce this, and I know you're not suggesting that, and I think important the committee would be aware of the demonstrable progress that has been made in relation to that issue, which has been an important issue both for this and other committees within the Assembly.
Another issue I hope you will accept as well, some, for instance, those who are partially sighted have been unable to get appropriate messages through a variety of means because of their limited or because of their disability, if you like, and the technology in our data systems. Would you accept there's another number of other benefits?
I think that would be a very important spin-off benefit, certainly, yes.
Thank you. I have Kieran next.
Yeah, Chair, thanks very much. Thanks very much for your presentation. I want to just talk about enforcement of targets and what the tools you have to ensure that the targets are carried out. And you have big issues with some correspondence, but there's a few other questions here that I would like maybe an answer. Is the monitoring of targets for waiting times for elective care completely delegated from the department to the board? Who leads on this area of work within the board? And do they have the expertise and resources in terms of time and staff to effectively keep on top of what the 5 trusts are doing? And does they approach a financial punishment of trusts who don't meet their core activity rates at work, and who is actually impacted by it? I noticed from your correspondence you do indicate that the board withdrew some 876,000 from 3 trusts, 2013, 2014, for not delivering against core activity. I mean, that was a punishment, but at the end of the day, who's at the end of that punishment? It must surely be the patient, is it?
Well, Dean, do you want to start maybe in terms of the board's role, and then I'll come in terms of what the department does?
Okay. Yep, happy to proceed on that basis. Certainly, if we go back to the legislation, the 2009 Act does make it clear that the board is responsible both for performance management and service improvement to ensure the delivery of ministerial standards and targets, of which elective care are clearly some of them. Who leads within the board at director level? We have a director of performance who's a colleague of mine, Michael Bloomfield. He and I work very closely together, obviously, in terms of the commissioning, the performance bits being 2 sides of the same coin. And we also work very closely with our finance colleagues as well. Do we have the necessary skills to do that? Well, certainly we have access within the board to a range of different skills. I think Michael and I have been directly involved with this now for getting on for 10 years previously in the department. We have, through the work that we did in the department more recently, secured at points in time substantial improvements in waiting times. I think what we're talking about today is how, in a very resource-constrained environment, with the demographic increases and pressures that Heather has referred to, how do we secure sustainably short waiting times? And I think that's certainly the where we're keen to focus. To answer your other question, do we have the necessary tools? Again, just to remind committee members what it is we actually do in terms of tools. What the most important tool, perhaps, is timely, robust information. We certainly have that. We have had that now in departmental days and now in the board for the last 7 years or so. So we know on a weekly basis what the numbers look like by organisation and so on. We have, with the agreement of the department and the minister, introduced last year the sanctions to which you refer to. Whereby if a trust materially underperforms against its agreed contract, then funding would be withdrawn at a marginal rate. That is what has happened. That shouldn't directly impact in the short term on any patient. It is more to encourage the right sort of behaviours within the system. But clearly, at scale, over time, there would be the risk in Northern Ireland in terms of an outcome in that regard. But it's trying to avoid the sanction being applied at all, Mr. McCarthy. Yeah. I think beyond that, it is coming back to what Heather was talking about before, which is the correct place for us to go, which is where all the discussion today has been about to date, is what can we do at scale in primary care to manage demand differently. And there are very active discussions with very senior members of primary care, both involving colleagues sitting beside me and myself. And one initiative in that regard at scale due to commence later this or during the summertime, in addition to a number of other smaller scale initiatives. Equally though, so in terms of better management of the demand at source in primary care, but equally though within trusts, trying to move away from what's quite an operational transactional arrangement with trusts at the minute, whereby as we speak Michael is meeting with 2 of the trusts this afternoon as part of a series of fortnightly meetings that we have with trusts, towards a less hands-on, less transactional, less operational arrangement, whereby trusts and clinicians are empowered with as Chris touched on earlier on, a greater focus on outcomes. And one of the key elements of that, not just actual patient outcomes, but obviously timely access to care, which in some case is a key prerequisite to a satisfactory outcome as well. So we are looking at the fundamentals of this and how we might reform things going into the future. The ways of saying.
Shall I add in terms of the department's role in that? It's twofold really. I mean, first of all, the board itself is an arm's length body of the department, and we do meet with them monthly. Dean and Michael, a report is produced in terms of performance right across the commissioning plan standards and targets, and we go through that in some detail, looking at individual trusts, where the areas of good performance are, where best practice can actually be identified and shared, and where performance is falling short, and what the reasons for that are, and actually what the board is doing about it in order to help trusts to improve. So that's one approach. Secondly, the trusts themselves, obviously again, are arm's length bodies of the department, and there is a very formal accountability and assurance process which is in place, whereby twice a year, mid-year and end-year, the trusts are brought in and a meeting is held with the chair, chief executive and senior members of the management team of the trust. It's chaired by our permanent secretary, and we formally hold them to account on a range of issues, such as a raft of corporate governance issues flowing from their governance statement. We look at their performance generally in terms of targets. We look at their performance in terms of finance. We look at their performance in terms of quality and safety. And the board is invited to those meetings and is invited to give their assessment of performance, and the trust is given the opportunity then to come back and give its report to the department as to the reasons behind any areas of underperformance. This year, this process is particularly significant, following a letter from the Permanent Secretary back in November of last year to all the trusts, which set out our commitment in the department to do a strategic assessment of the Trust's position on quality, finance and performance, and that will be completed when we do this round of end-year assurance and accountability meetings. And in fact, that letter of the Permanent Secretary held out the possibility of further intervention on foot of that process, if and escalation is a possibility if that's required.
Just to follow on or finish, Chair, in relation to, and it does concern me, for instance, I mentioned that £876,000 was taken off the trust. I mean, I'm looking here at, in England, for instance, they use what's called targets and terror approach. Do you know what's coming here? Where chief executives lost their jobs, and that, that's putting the blame or the responsibility on not delivering what was expected of them, other than or rather than taking cash from the trust, which obviously will come down to the patients. That hasn't happened here, at least I haven't heard about it. Well, is it likely to happen in the near future? And also in Portugal, they use an approach of offering incentives. Only doctors who had met their basic targets were permitted to do additional in-house work. Anything like that?
I suppose to come back to how it actually manifests itself, we withdraw funding for services not delivered at 25%. In reality, that at 25% would be largely related to consumables and so on associated with that activity that might have been incurred anyway. So at the minute, I don't think there is I'm fairly certain there isn't a material impact on other patients within that LCG or trust area. The total figure, just for the committee to be aware of, in terms of the 3 quarters in 13-14, which would supersede the information you have, is approximately £1.5 million has been withdrawn now for under delivery. I don't want to get into a place, departmental colleagues will have a view, I don't think it is helpful for all of us to get into some sort of a blame culture. It is about trying to create a system where, in particular, clinicians in primary care, clinicians in secondary care, are facilitated to do the right things for patients. And we can hopefully avoid sanctions, threats, terror, or anything other unpleasantness. This is all much more straightforward for all of us, and particularly for the patients, if actually they receive timely access to care. So certainly I'm confident that's the direction the Minister and the Department are continuing to work towards, and it's certainly the direction, I can speak on behalf of the Board, that we're seeking to work towards. That doesn't mean that from time to time, as currently, we won't face particular challenges. I would encourage committee members, though, to look at the movement in these numbers over time, and to be assured that between the Department and the Board, we will turn this around. There are challenges with that, and we've talked about some of those, but I think we have the building blocks to allow that to be turned around. The difficulty is because it's at such a scale, it's not just a quick flick of a switch, so to do.
Just to finish, Chair, I mean, until we see real efforts to get on top of this, it's going to continue and continue. I would, if you come back to here this time next year, will we be seeing the same problem?
I suppose I would assure committee members from the Board's perspective, there are real efforts every day of every week looking at this as a specific agenda issue. This isn't something that we come around to once a month at all. It is something that there's an acute focus on within the Board, and indeed within trusts as well. Probably bluntly too much of a focus on it, because there's bigger prizes around transforming your care that we need to be focusing on, and almost making this part of routine business. Clearly the two aren't unconnected, particularly the demand management initiatives within primary care, and the discussions with leaders in that regard are entirely consistent with the Minister's vision as set out within TYC. But that's where we need to be focusing on, and the other being more just routine business.
Okay, thanks, Chair.
If I
might come in on this, Chris, because I think it is important, Dean, that where there is a role for the committee in relation to understanding both the Department and the Board view or policy on a specific way forward. And I think Kieran's question was in and around those kind of financial almost punishments, and the use of those. Did they actually achieve anything? And what I'm hearing from you is almost a sense that we don't want to move to that blame culture. So if we're saying that, are we saying then that we look at a process of incentives? And if we look at incentives, what will the incentives be?
Okay. I think it is always helpful to, I commission services, so if any of us in our day lives, if we're going to Tesco's, we're not spending money for things that we don't receive. So I reserve the right, and I think you would expect me, working on your behalf, to have a position that if routinely over time services weren't delivered in the required volume or to the required standard, there would be some come back to the relevant provider in that regard. That seems entirely reasonable, and that doesn't sound to me like a sanction or anything. That's just routine commissioning from a provider organisation. I think what I was trying to explain, Chair, was my desire and the Board's desire not to get to a place where every problem becomes an opportunity for everyone to point fingers at everybody else within the system. I would rather that our collective efforts were spent on trying to fix the thing. So if it was unclear responding to Mr McCarthy, I apologise. What I was simply trying to say was we are at a place that we're at the minute. We are trying to avoid any blame culture. I don't think where we are now is and I saw the quote in terms of the threat and terror from across the water. I think they have been in a slightly different position from us in that regard, but they're a different system at a different scale from us.
Just specifically, James, sorry, because I know there's a number of people want in on this particular issue as well. The incentives culture.
Right. Well, on the incentives culture, then I touched on the board having progressed discussions with a small number of provider organisations within Northern Ireland in recent months around a small number of specialties. And really that discussion has been a much more open-ended discussion with them, which is, can we move away from a transactional-based approach to this, whereby my relationship with you as a provider is to buy 3 of these and 4 of these and 5 of these, to an arrangement whereby my relationship with you is to ensure that you provide timely, effective care on a long-term sustainable basis for the population that via the LCG you serve. We, as part of that, Chair, are actively looking at what incentives that we might put in place in the context of that being delivered. The flip side of that would be, though, potentially not paying for services when they're not delivered. But I think the point is well made. It is often easier to design the sanctions bit of this than it is to incentivise. I think the biggest incentive, though, and certainly what has been very, very well received, and these are discussions actively with clinicians, with orthopaedic surgeons, with urologists and others, the biggest incentive for them is to give them a little bit more control over their day life. So saying to them, putting the challenge to them, because I've heard, and I would, in the nature of my job, routinely meet with clinicians, that if only we were untethered from all of the bureaucracy and so on, we could do so much more for patients. We are, as an organisation, supported by the department, putting that challenge out to the clinical groups now and saying, well, show us what that looks like. It needs to be within broadly acceptable parameters from a commissioning perspective, but show us what that looks like.
Okay, and we'd like to be kept informed as that particular piece of work
happy to.
is rolled out on this. I know there was... Chris, sorry,
Sorry,
you wanted to
Chair,
comment.
yes, if I could just add a couple of points, I think, to amplify Dean's answer there. I mean, I think the ultimate incentive is to empower clinicians to make better, more efficient, more effective use of the resources that we have. Now, central to that, of course, will be mechanisms like integrated care partnerships, which members will be familiar with. But to give you a more local example of where this can be extremely powerful, some work that was pioneered in the Northern Trust by Professor Mike Scott and now being rolled out across all the trusts on medicines management. I won't detain members with the fine detail of it, we'd be happy to send it to you. But essentially some very progressive software packages which have made a step change in the way the medicines regime is applied to patients in hospitals. And as a direct result of that, the average length of stay in hospitals has been reduced by 2 days. And of course, that frees up capacity within the hospitals and frees up the capacity to admit more patients and to increase the throughput. That has come about through the empowerment of Professor Scott and his fellow clinicians in the trusts to innovate, to develop good practice, to have that recognised by the board and by the department, and to be rolled out and replicated relatively quickly. I think we could still do better in this regard, but relatively quickly across the HSC.
Thank you for that. Gordon?
Thanks, Chair. Thanks very much, folks, for coming in this afternoon. Just a couple of quick things. Does your data include the A&E waiting times and trolley wait times? It does. Right. How is it managed differently from the rest? Just briefly, without getting bogged down.
Well, I suppose, if I may start there, Chair, one of the key ways that it is measured differently, the waiting time side of things, for planned care, which is what elective care is, we tend to track that on a weekly basis, weekly, fortnightly, monthly. A&E waiting times, we have live feeds, so colleagues within the board would know now what the position is like across all the A&E departments within Northern Ireland. I get an update every morning at 9 o'clock, which tells me what the position is like, another one at 4 o'clock in the afternoon, as do other senior board colleagues. The principles are broadly the same. The principles are, we would seek to identify the demand from patients within an LCG area for services, to commission services consistent with that demand, and then hold providers to account for the delivery of the services that have been commissioned. So the principles are almost identical to the elective care. The key difference is there wouldn't be the independent sector opportunity to deal with excess pressure within the system. We are wholly reliant for that demand that presents within trusts. We are wholly reliant on the ability of trusts to deliver timely and effective services to
Fairly
patients.
predictable, though, the figures, aren't they?
Mm-hmm.
Which we found, we went to visit the Royal, we learned that that day, that they are predictable. We always felt that they were unpredictable, but they gave us the assurance that they are fairly predictable.
Mm-hmm.
So why aren't we managing resources better then?
Well, I can speak from a commissioning perspective. I am satisfied that we have worked very closely with trusts over a prolonged period now to be reassured as to the sufficiency of resource that exists within trusts to deliver timely access to care. That's not to say that there haven't been and aren't always opportunities on a issue-by-issue basis, potentially to invest to improve patient flow within the system. But the resources are there now to deliver reasonable performance against the Minister's extant waiting times. I think that's easy for me to say today. The very real challenges around actually delivering that, given the complexities in the patient journey, given the challenges that trusts have had. And whilst the front door, as you say, Mr. Dunn, is reasonably predictable in terms and actually fairly steady in both the time of day and day of week demand, one of the remaining and continuing challenges for trust is to keep their discharge performance equally steady, both during the days of the week and the times of the day. The greater is the extent to which discharges are pushed into later in the day, into the evening time, and the greater is the extent to which the flow of discharges doesn't happen over the weekend, the greater are the pressures then in terms of the ability of the front door of the system through ED. And as I know you will all know, ED pressures are only a symptom of the system itself not flowing through. At the end of the day, by definition, all patients eventually get discharge, and over time, admissions equal discharges. It is only a timing thing where we have blockages in the system that prevent the flow working as it should.
Just my other point, back to the enforcement, is there a risk that the frontline staff are under excessive pressure to meet targets? We have got it, first hand from staff that within wards, staff are told by managers that these patients are going to breach. Now, is that putting patients at risk in relation to their standard of care, where managers are more worried about reaching the target than they are about the condition of the patient or the level of care? Do you feel that is an area of risk?
If that was to happen, that would be an area of risk, and certainly right the way through the system from the highest level, from the Minister down, and has been said by the Permanent Secretary, by the Board Chief Executive and by Trust Chief Executives. That just would not be countenance any suggestion that we should be chasing targets rather than prioritising patient care. Having said that, I can see how in extremis suboptimal decisions might be thought about being made, and I think that's just human nature. And all I would reassure committee members is of the ongoing reminder, reinforcement from the highest level within organisations, particularly within provider organisations, that patient care, patient outcomes, patient needs are paramount and the targets are secondary. That's not to say that the targets aren't in themselves important measures, but when it comes down to an individual patient, it's about making the right decision for that patient.
And I think as well too, we need to be mindful that what we're dealing with is elective care, and that we're getting straying into a conversation, albeit an important one, but straying into a conversation around
Chair, it actually reinforces the point that the two systems are interconnected, because it is about patient flow, so they are relevant, and it is a whole system approach.
I think that the principles are similar, that some of the symptoms coming from those systems are different, however.
Sorry, Chair, just on that, Dean, you indicated something earlier about saying that even you felt there was too much effort to be focused on meeting targets, and rather than dealing with issues like TYC,
I don't think, Mr. Dunn, I said there was too much effort on meeting targets per se. I think we can spend too much time and focus on what should be qualified. As always, we're working in very complex systems, dealing with millions of people or patient episodes every year. it's important that we ensure just as much or more of a focus on transformation of services looking ahead as we do on the here and now. Now that's a juggling act in terms of managing competing priorities, but that's where we've got to be going, because if we don't get the transformation bit right, we're into some sort of a tailspin, difficult performance now that's going to become even more difficult in the future because of the pressures that we talked about already. And if you would maybe just humour me just to come back to, because Mr. Dunn, your point around unscheduled care is right. The initiative I talked about with trusts, in terms of saying to clinicians in trusts, tell us what you would do differently, is a discussion around elective care primarily, but does pick up the unscheduled care. So if it was in urology, it's not just about the planned patients, it's also about the emergency patients, because clearly a urologist, for example, is doing both. Yeah. And I think if I was to hold the mirror up to my approach to commissioning, maybe it has been too siloed down that we do elective care and we do unscheduled care. So as we all need to learn as we go forward, trying to recognise that at the end of the day, trust teams work as single teams, and therefore it might unlock some opportunities for us if they think of things in the entirety of both the planned and unplanned work.
Okay, thanks very much.
Okay.
Thanks, Chair.
Okay, thank you, David. I think this is on enforcement, on the same theme.
It is,
Okay.
Chair, thank you. And I think Gordon Dunn has taken this to maybe an interesting place as well. And it is maybe just following on a little bit from that. Heather, you mentioned in your opening comments around the issue of capacity. And obviously capacity is very important. So would I be right in thinking that in that context, any suggestions to reduce capacity within the system at the moment would be, I guess, nothing short of irresponsible? And I mean, I've got a specific case obviously in mind, in that, for some time now the axe has been hanging over Causeway Hospital in the Northern Trust with concerns over closure of certain departments. And would it not be helpful in the environment that we're now in for that axe to be lifted from Causeway? Some may argue that it's not there at all, but I think most of us who are there locally know that it is. And that has been resulting in capacity issues when it comes to medical staff actually wanting to even be employed in the hospital, because nobody wants to work in a hospital that's about to be closed, or it certainly is going to have departments closed. So do you feel that it would be helpful at this stage for a very clear message to be sent out for those departments, whether ED or whether elective, that are facing a threat to their future, that in this context that perhaps that threat should be lifted?
That's a difficult issue for me to comment on. I mean, taking capacity in itself, I think it's very clear that the system is under pressure in terms of capacity right across the board. And the work that the HSEB has done to do the demand capacity analysis shows that, and there are some specialties which are under more pressure than others. In terms of where the capacity that exists is deployed, I mean, clearly that's an issue for individual trusts, and decisions have to be made which take into account a range of things, not least quality and safety for patients, as to where particular services are carried out. So I think that's a separate consideration in terms of location of services, particularly in a jurisdiction which is the size of Northern Ireland. But that's a different point from the overall availability and the overall capacity that exists, and that is certainly under pressure, so you're absolutely right.
So are you saying...
So I can't comment on in relation to the
But okay, let's take it away from the specific, but in the general, would you accept that to the public it would seem very bizarre to be in one hand saying that we are already at the limit of our capacity, but on the other hand effectively then reducing it?
I think what the public want is a service which is timely and which is top quality, and so what we need to do is put in place that service. I think the public are probably more concerned with that than specific location. They want the right service, and they want it to the highest available standard that we can provide.
Thank you, Chair.
Okay, thank you. I have Fergal next.
Thank you very much, Chair. Pardon me. First of all, can apologise for not being in at the start of your comments, though I caught tail end of what you were talking about, and I see some of the direction of travel. Slightly concerned about the idea of just monitoring elsewhere, which leads me to the core of what I'm asking, which is who exactly has responsibility for managing, reducing waiting lists, waiting time, in Northern Ireland?
Okay. Well, first of all, the primary responsibility is on each individual trust to deliver what it has been commissioned to do.
Can I stop you there?
Yes.
Who has the ultimate responsibility for reducing waiting times in Northern Ireland? Who has the strategic responsibility?
Ultimately, the Minister.
Well, he can't do it as part of his day job, so who does he defer to?
Absolutely. So he defers on a day-to-day basis. It's to the board to manage the performance of the trusts, and then the department manages and monitors the performance of the board as one of its arm's-length bodies.
And can you just outline for me, if you would, what the clear responsibilities are then for the department, for the board and the trusts?
Okay. So the trust's responsibility is to deliver the activity which has been commissioned by the board. So the board sets out the levels of service that it is giving money for, and the trust is contracted to deliver that. Dean explained earlier what the board's process is in terms of monitoring their progress in terms of delivering it, and he discussed the fact that in this year and previous year an element of funding was withdrawn because in certain specialities the level of commission service had not been provided. So there's a process there which the board looks at, and they have the demand capacity analysis, so they know when trusts are delivering to the levels that they expect. What the department does then on a monthly basis is receive a report in from the board setting out performance against the standards and targets that we set, because ultimately that's the department's responsibility and the Minister's responsibility to set out the levels that we expect. So we then hold the board to account in terms of the work that they do to monitor the trusts and the work that they do to not only tackle poor performance but actually look at good performance, because there are areas of good performance, and so what can be done to share that more widely?
I suppose if I could phrase the question another way, who owns the waiting time problem?
We all do, yes. It's a shared responsibility, but ultimately the Minister is responsible.
I know, but sometimes sharing responsibility is a good thing, and sometimes it takes somebody to take charge. So has the department ever considered putting somebody in charge to get this problem sorted?
In effect, that's what happened. We have a performance process,
That's
management
a process. I'm saying, is there a person or a team that you've ever considered to be put in charge of dealing with waiting times, given the scale of the problem?
Part of... Sorry.
Right, there are a number of people in the department who share that responsibility. Part of my responsibility is to make sure the information is there to inform progress against the target. Part of Heather's responsibility there is to chase up the performance management and oversight of the boards in their role as trying to manage the trust in order to be able to deliver that. And the Minister in the department will set out these clearly in the Commission plan direction, saying exactly what he wants. So
I understand that, but we've got a problem, and you value, as you've said earlier on, the work of the committee, and this committee is bringing in evidence from elsewhere, and it's interesting evidence and it has to be evaluated. I'm concerned, as I say, that you're waiting for all of this to, filter down. But if you were to change the system, surely you would need somebody then in charge as a team. It would set some direction, and it would send a signal that there was a mechanism now going to be put in place to make a difference. So, is there such a mechanism? Is there such a core responsibility for dealing with this issue in either the current way and achieving better outcomes, or changing that?
I think the teams are in place. I mean, certainly my team, one of my
So
branches,
are they
was
actively
responsible
considering some of the mechanisms, for example, in Scotland and Portugal and elsewhere? Are they?
We have been monitoring the work that the committee has done, because it is...
No, that's our work.
Yes,
What's
and
your
it's
work?
and actually that is going to feed into what we do. And at this precise moment in time, we're gearing up for these assurance and accountability meetings, which are going to take place over the next month or two in order to be very clear about how the trusts are currently performing. And as I said earlier, this year is particularly significant because we have undertaken to do an exercise which looks right across the performance of the trusts in terms of how they fared in terms of quality and safety, and how they fared in terms of their financial process as well, so that we can come to a view of the overall position. And then I think that's the point at which we make decisions, we make recommendations to the ministers.
Mr. McKinney, if I might just sort of interject there, if I can, what I would suggest might be helpful for the committee to look at, if you haven't looked at, is just trace the story back in Northern Ireland to about 1995, because there's lessons to be learned from the past and the risk of reinventing things that haven't worked and thinking we're reinventing something that has worked. So most of the sort of approaches you're describing have been tried in one way or another. There was a service improvement unit established in 2003, 2002, with quite a fanfare around it that didn't have a huge impact at the time. I was in the department from 2004 to 2010 and was directly involved in an initiative that did have a big impact. It's not down, I don't think. My personal view and the view of the board, I would suggest, would be that I'm not sure if what we're alluding to is having a single person in charge of this across Northern Ireland, and different to the structures that we have, is necessarily the magic bullet that we're looking for here. I would be happy to say, I said earlier on, if you're looking to the closest that the system gets to having an access point here would be the board. The board has responsibility, as is set out within legislation, for ensuring the delivery of the minister's targets, working with trusts, being held to account by the department. We're not, but just to reassure, as I've hopefully given a flavour of already, I would be as acutely aware as anyone around the table of the current performance not being acceptable as I was back in the department in 2004, where we, not prompted by any wider process, put in place something that transformed things. I would reassure the committee. I was working with Michael Bloomfield at the time then. He was part of the team that I worked with within the department. We will turn it around. Again, it is more difficult now. We have faced a lot more competing challenges on resources now, that the demographic position is massively different now as well. But I would assure you that all of the things that we should be thinking about, we are thinking about. I think I look forward to the committee's recommendations, because we can always learn as well.
Of course. But earlier on I heard you saying that you didn't favour the sort of targets and terror and that robust approach, and now you're saying you don't favour the necessarily that an individual. But how are you evaluating that?
Again, this was the subtle differences in words. I said I wouldn't like to get to a place where we're reliant on some terror arrangement, but I was instrumental in the introduction in Northern Ireland of not just elective care targets. The whole target regime that we have can be fed back to arrangements that were put in place in 2005 under my direction within the department. So I know the importance of having absolutely clear targets, of having robust monitoring arrangements in place linked to those targets, of having incentives and sanctions when those targets aren't delivered, and having escalation arrangements. That's our mantra, our performance wheel. That's still where I am. I suppose what I was trying to convey, though, is if that's all you can rely on is the big stick and the threat of something when it's not delivered, that it doesn't feel like a sustainable position for me. We've got to get to a place where most of the time, most of the things are routinely delivered, and not just in a big push to try and get over the line in a 12-month window. As I look back, we made huge strides between 2005 and 2008 in terms of unscheduled care, elective care, ambulance waiting times, cancer waiting times, and so on and so forth. And I would encourage you to look at those numbers to see just how much change can be made by the present incumbents. It's the same people there now. The context is different now, though.
Yes. And I accept what you're saying. I'm just asking, are there evaluations being done on that? Clearly, the work that's been done hasn't arrived at the position that we would prefer to be. There are other models out there. The committee has been looking at those. Had you looked at them, we wouldn't have had to look at them.
Okay.
So who's taking responsibility?
Well, I would assure the committee I am personally taking responsibility for improving arrangements in place between the board and primary care to switch off demand at source through maximising the skills that exist within primary care. Not with a formal evaluation, perhaps.
But should there be a departmental focus? A team whose job it is to enforce, and I use that word in its broadest sense, if you like. Sorry, Gordon.
You're okay, go ahead.
I mean, I use that, in other words, that's the job. Should there be another tier, another function to look at this to ultimately resolve it? Because, and with respect, I hear what you're saying and I respect the work that you're doing, but it's taken time and the results aren't still there.
But I also think it's not just a simple case of putting in a team to sort out the elective care waiting list problem. It's because a whole system approach is required, and as we said earlier, unscheduled care impacts on elective care, workforce planning impacts on elective care. The financial situation is currently impacting on the delivery of these standards and targets. So in effect, that one team would have to tackle the entire work of the department. It would be too big for any one team to take on, but there is a team in place which works with the board to monitor performance.
But substantially, that's different from what I'm talking about. Yeah. Monitoring is different from leading in that sense. Sure.
And I think as well, I mean, there have been teams created elsewhere on the specific issue, which didn't necessarily have to look at the entire system or the whole system. But what I'm hearing, Dean, I'm hearing a lot of we don't want to move to targets on terror. We've had a unit or a special unit set up before that seemed to have had some impact, but then you acknowledge that it didn't have the impact that we would have desired or wanted collectively. So I suppose, what is it that you collectively as a department or as a board need? You know, what is it? What is the ask in relation to this question?
Investment, Chair.
Yeah.
Investment.
So it is resources.
It's resources in order to provide the additional capacity which we know that we need in order to meet increasing demand, but also on the other hand, it's been able to manage down the demand as far as possible, and we need to do both.
Yeah.
We need to do both.
So was, in your acknowledgement, Dean, that it didn't have the desired impact on, I think, was it 2004? 2005?
No, there was, as I say, I'd be happy, Chair, I'm sure departmental colleagues would be happy to share with you the sort of history of all of this in terms of the different approaches. I was referring to the board, the department established a service delivery unit in 2006 that is now part of the board. It morphed from being part of the department into part of the board with the RPA Phase 2 in 2009. That is still there now. Today, that is part of Michael Bloomfield's team that I talked about before. The vast majority of the same staff are still working there now. All of the performance information arrangements and so on are still there. The same approaches to interacting with trusts are still there. As colleagues have said, they were just working within a very different context from that at the time. Now, when I was talking about something that didn't work, there wasn't demonstrable evidence from the previous initiative to that, which was set up in, I think, about 2002, that didn't actually result in any material change to the numbers. The numbers moved in the way that Mr McKinney was referring to from 2005 onwards, with very specific focused inputs. I think where we find ourselves now is in a place that's more difficult, more challenging than that, but still fixable. And what I was going to say, what might be helpful, Chair, if you wished, I have what I believe to be the 5 or 6 particular issues for us today as to why performance is the way it is within elective care. I don't know whether that's helpful to have now or whether you'd like us to perhaps drop a note to the committee afterwards.
Yeah, well, we can have that information. We can take that information from you and reflect on it. But I suppose it is a question, and I know Roy wants in on this as well, but in terms of that strategic leadership, if we're saying that there was a special unit set up which was then morphed, in your words, within the department,
within the board.
within the board.
To the board.
So, you know,
Still there's-
does that need to change?
I don't believe so. If you were to say to me, Dean, the committee's view is there's an absence of effective engagement with primary care at a senior level to fundamentally change the approach to demand management, I would say the committee is misinformed, because there is, and there has, but only for the last number of months at a very senior level, including Tom Black in that regard, and that will bear fruit, I would assure the committee later on this year.
It's not about engagement at that, sorry, Dean, with respect, it's not about engagement at that level. It is about the leadership and management and strategic direction of dealing with waiting times around elective care.
Right, well, let's go through the component parts of that. Why is there an elective care problem? One of the reasons why there's an elective care problem is that demand has increased by 12% in the last 2 years. And within that overall increase of 12% in the last two years, there's significant spikes in particular specialties and or particular LCG areas. We have to find a way of sustainably holding demand at a manageable level. That's why I'm having the strategic discussions personally with Tom Black and senior colleagues within primary care land, with a view to putting in place arrangements that will deliver that for us. Is that side of things, that we get to a place, you've seen the work that the board has done in relation to demand and capacity, that we'll get to a place that I would know that there will be 2,000 referrals, not only in 13-14 in Specialty X in LCG Area A, but in 14-15 and 15-16, because that would be the nature of the arrangement with primary care to deliver that. Separately to that, once we have a hold on the demand position and at scale across specialties across Northern Ireland, to have a hold on the trust side of things, which is the one that I described earlier on, which is again at scale within a specialty, covering off both the planned and unplanned work, that we're not into widget counting individual bits of activity, that instead what we are doing is having a more strategic relationship with the trust to deliver reasonable waiting times consistent with extant standards over that similar period of time. That feels like a position which is covering off exactly the sort of concerns I think you're raising, which I think are the right concerns, which is not more of the same. We know not more of the same, because not more of the same isn't going to fix it. There's not enough capacity in trusts in the independent sector to continue doing what we need to do. We are needing to ramp things up within trusts in terms of bringing clinicians to the fore, and equally give GPs much more of an opportunity to manage things differently at their side.
Did I just come in?
Sure, I knew.
And that's all ambition, and it's all it's where you're trying to aim to get to somewhere. And I don't want to use this as cracking the whip, but I do want to put it into imaginative ways of doing it differently, but where the power rests with those people that are charged with that. Mm-hmm. And will power at that level make a difference? And does it exist now?
Well, if I may speak just on, I don't feel any lacking of power or authority or ability to make change.
Yes, but the waiting times still exist.
That comes back to, though, where we start. A lot of factors to bring to the table. Where did we start in 13-14? We started in 13-14, and useful to rehearse this again, where I know by specialty, by trust, what the capacity is of each organisation. I know by LCG, by specialty, what the demand is expected to be. Where that demand is expected to be more than the capacity, my expectation is that we will secure that in the first place by additionality from within the trust, and where that's not possible by purchasing capacity from the independent sector, is where the 13-14 year started from. And again, if we track the history of this, 10-11 into 11-12 into 12-13, all successive significant reductions in waiting times. 13-14 has been a poor year. 13-14 has been a poor year because demand has spiked within particular specialties, because beyond that we had planned for, because there was no contingency in our planning. We simply don't have the resources to send 100 patients out to the IS, and we'll send another 20 out just in case demand is higher. So this year demand has been higher than we forecast. There have been some difficulties in terms of delivery of core capacity by trusts, and crucially, in terms of buying independent sector capacity, there has been some difficulties for the first time, or certainly for the first time to this scale, identifying independent sector providers that can deliver certain types of work at the volumes we require and, crucially, at the price that we can pay. So those three things combined have conflated to create a place where it doesn't, all three of them all pulling in the wrong direction, under delivery of core, over delivery, it's a greater demand than forecast, and under delivery of independent sector planned activity, all very quickly generate hundreds and thousands numbers.
I think Roy wanted in on this same issue, and then Chris will.
There's been significant increases in a range of the waiting list times for inpatient admission, in terms of those waiting for procedures as well, and you seem to be putting that down to lack of capacity to outsource. Have you looked at seeing how you can more efficiently deal with spikes within house, and why are you not increasingly doing that if there is virtually a monopoly outside in the private sector? So has that aspect been adequately looked at? And finally, the other aspect is you're saying that we've been significant difficulties this year in terms of there's been a resource issue amongst other things, but the health trust or the health service did get over £100 million in your monitoring, more than ever before. So why has that happened?
Okay. Well, dealing with the first question in terms of the ability of the system to deal with those spikes in demand, the arrangement that I referred to, the more mature arrangements with trusts around a long-term strategic deal effectively with an individual specialty, is precisely that unless demand moves massively beyond what a reasonable expectation would be, the expectation of myself and LCG colleagues would be that demand would be responded to by the provider. That's not the arrangement routinely at the minute. We're in more of a transactional operational arrangement at the minute, whereby Trust prime focus, not only focus, but prime focus is on delivering activity. And the waiting times are more of an outcome product of all of that. If Trust deliver activity and demand is greater than that, the waiting time is what the waiting time is. More generally, on the resourcing side of things, there are a number of draws on resources within health and social care. Again, as I'm sure committee members have been briefed on before, cost pressures running at circa 6% per year within health and social care. Increases in income running at about 2.25%. Health and social care across trusts, crucially, but also within pharmacy and primary care, have delivered cash saving and productivity improvements of £450 million cumulatively in the last 3 years. The system is running hard to stand still in some areas, and inevitably it reads through. I've already given you an example in terms of independent sector spend, where certainly, and I was very directly in a very similar role to the role I have now within the board, in direct drive mode back in 2005 through to 2009, we would have built in a much greater tolerance in terms of sending patients out to the IS, because we could afford to. We could afford to deal with spikes in demand by building in tolerance, building in contingency. And if you look at the numbers, you will see massive numbers that are 55,000 outpatient waiters more than 9 weeks in January 2007, became about 25 at the end of March. So numbers delivered down hard to zero, or as near to zero as makes no difference. It is much more difficult to do that now within the financial context that we're all working within. That's not to say that there aren't huge pressures across the public sector. We know clearly there are, but we're here to talk about HSC.
How do you look at the value for money aspect of simply farming it all out to deal with the
Sorry, Mr. Briggs, I missed the start of that.
Pardon?
I missed the start of that question.
I didn't hear you address the aspect of how you identify value for money aspect of whether you farm everything out that's going to be every year annually, generally from January to March. A lot goes to the private sector. the value for money aspect of doing that rather than trying to find a more efficient way of dealing with it perhaps in-house? I mean, have you got the numbers to justify?
I know
the
maybe
money
at
doing
this
it?
point, Roy, sorry, because I know that one of the issues we wanted to address with you was the role of the private sector, and I know
Right, sorry.
and we're moving into that now, and I know that both Mickey and Pam had indicated that they wanted to take some of those places forward. So if you want at this point, because it's in a similar vein, either Mickey or Pam to come in at this point, and we'll address them then collectively.
Thank you, Chair. Thank you for your presentation today. And yes, use of the private sector is obviously of great interest to the committee, and it's obviously a key issue. And the committee has learned that in countries which have had success in bringing down waiting times, the private sector is used in a limited way. For example, England, Scotland, the private sector is used to provide additional capacity at margins which is not required all year round. In Portugal, they have a voucher system whereby if a patient reaches 75% of the maximum waiting time, they're issued with a voucher which can be used in a private hospital. However, there's many of the experts pointed to potential difficulties of having a mixed public-private model for elective care. So I have a few questions here. Can you tell us what contracts currently exist with the private sector for elective care? And could you also tell us how much those contracts are worth and how many years they've been signed up to?
Okay, I'll maybe deal with that one. I wouldn't have a list of every single independent sector contract, but certainly we can let the committee have that. In terms of spend on the independent sector, it has been broadly in the sort of 55 to high 60s range since 2009-10, 57.5 million in 2009-10, 66 million in 13-14. The board has made clear, the department has made clear on numerous occasions our desire not to be reliant on the independent sector, certainly not to be reliant on it to the extent that we are. I know those numbers sound big, they only account for about 5% of total elective activity. So in absolute terms they are small, but my view would be they are still too large, and that would not be a position I would wish to have going forwards. I would encourage committee members to distinguish between the use of the independent sector to reduce long backlogs and what a sustainable equilibrium position might be. There's always going to be, from time to time, for various reasons, the need to clear a backlog. That was certainly the case when I go back to 2005, 6, 7. And the desire to get to a place that really the system washes its own face. That's exactly what I was trying to describe earlier on in the evidence I was giving, in terms of our desire to get to a place that demand in primary care is locked down, that delivery in secondary care is locked down, and the two together, providing the output of one is the same as the expected input to the other. That does lock it down. It would be my expectation that in principle we should be able to get there or close to there in the vast majority of specialties, with the exception of orthopaedics. Orthopaedics is at a whole different scale. There simply aren't the orthopaedic surgeons, the theatre capacity, and other key constraints within Northern Ireland to allow us straightforwardly to respond to that from within the public sector. So there will, for some time, continue to be a need to utilise the independent sector in that regard. But it would be my desire and hope that, following the initiatives I was referring to earlier on, that we can move to less reliance on the independent sector in other areas, because no one really it is useful in exactly the way you're describing, at the margins when there's a particular issue to respond to, but not as a sustainable ongoing way of doing business. Is not the way we would wish to be commissioning routinely.
Okay, thank you. And you probably partially answered my next question, which was, what is the department's long-term approach to the use of the private sector?
I think it's as Dean has said. I mean, they're an unnecessary part of the picture in order to meet short-term need, but ultimately we want to see a position where there is not wholesale reliance on the independent sector.
Okay.
Okay, thank you for that, Pam. Maggie?
Thanks for the presentation. Without, and I'm sure I will be accused of repeating myself, but if you're taking a cynical view of transforming your care, you might consider it's not so much a shift to the left there's a shift towards privatisation, but that's a view. I'm just wondering, has the department put in place any policies to prevent the same consultant treating patients in both the public and the private sector?
There are workforce policies in place, and certainly that is dealt with in the contracts that consultants have. Very stringent arrangements are in place. Doctors may combine work in the public sector with private sector practice. However, it's regulated and they must declare it. And if they conduct private work in trust premises, well then the trusts basically make sure that they take back the costs associated with that, so that they're not out any money as a result of it. So that area is very, very closely monitored by the trusts who employ the consultants.
No, I mean, there is anecdotal evidence of consultants using public facilities in their private capacity, and then presumably, and again this is anecdotal, incorporating that cost within the charge for the private.
They pass on the charge to the patient. They may well do that, but ultimately the public purse is not penalised as a result of it, because the trust certainly captures that cost. The patient,
And we've been talking all day today about the patient as the priority.
Yes.
So obviously that's something that needs to be addressed. There's also anecdotal evidence of consultants who treat patients in the public sector passing on the information that they also do work in the private capacity. And is that something that needs to be addressed, which obviously it does? Is there anything in place to address that?
Well, certainly I'm not aware of that. Well, we can look into that.
No, it is, I mean, again, as I said, it's anecdotal evidence, and obviously we on a constituency basis deal with a lot of health issues. That certainly is something that I've come across in the past, and the use of public facilities in terms of the private sector.
I'm happy to take that back to workforce colleagues.
Thank you.
If I might just add to that briefly, I mean, we recognise the importance of the issue. There's always a tension between the capability of someone to work in both the public and the private sectors. That's a tension that exists not only in the HSE in Northern Ireland, but in the NHS and in other parts of the UK. In doing whatever we might do in that, I think we just need to be conscious that it's at least a UK-wide employment market, if not broader than that. So if we were to make a change, perhaps to restrict that further than is currently the case here in Northern Ireland, that could have an effect on the employment market and our ability to fill important posts.
No, I think I'd accept that, but again, if the patient is the priority, there is anecdotal evidence that some consultants are more interested in doing private work than they are contractual work within the National Health Service. I mean, that's something that needs to be looked at and addressed, because you have to strike a balance. But ultimately, if we have a service that is free at the point of delivery, then it seems to me slightly contradictory if people who are doing that work are then allowed to go off and do other work, which then impacts on waiting times, etc., etc. And that surely is one of the issues that we're trying to curtail in that sense.
Well, certainly, as Heather said, there's a very clear set of rules around this in terms of the only basis on which consultants can undertake work in the private sector, and it's after demonstrable evidence that they've delivered the expectations in the public contract.
I think enforceability.
I think that's a big rule for trust management there. I think the other point you mentioned, Mr. Brady, around the risk or the anecdotal evidence you have of a potential risk of patients being advised by consultants to see them in the private sector. I would have no evidence myself of that, but I could see how the longer are the waiting times, the greater is that risk, and the greater, more generally, is the risk/need that patients will see that as a necessary evil for them, that where they should reasonably expect to receive timely care within the HSE, they feel that they have no choice but to go to the private sector. It takes us back full circle again, that the prime objective for us is to fix this at source, not to have long waiting times. If patients know they're going to be seen in outpatients within 9 weeks, there would be little or no incentive for them to pay privately to be seen.
But you can see why that can happen, because you are then reducing your resources and your capability if someone is being given that offer. And ultimately, surely one of the issues is to protect the National Health Service. It's one of the few bastions left that needs to be and should be protected at all costs. You know, and it just seems that the move towards privatisation is totally undermining what has been and continues to be a very, very good service. You know, sometimes we do look at the negatives, but sometimes we do have to look at the positives. You know?
Like certainly in the context of the discussion we've had today, there is categorically no move towards privatising anything, quite the reverse. You know, all of the initiatives I've talked about within primary care, the desire within the public sector, within secondary care, that they would offer a more holistic wraparound service and deliver the outcomes that patients expect.
What's this space then? Really?
Yeah.
But I think as well, thank you, Mickey. I think as well that the issue is not about the tension that you refer to between public and private. It's as you rightly pointed out, it's more than a tension. It could potentially be a conflict.
Good.
And you know, whilst I'm listening that you're saying there is no appetite to move towards greater privatisation than already exists, there are examples of, for example, in Scotland, where certain boards wouldn't use consultants from their particular areas to ensure that there wasn't that. No, so I suppose what the question today to you is, what are you doing to ensure that that conflict doesn't exist? And what I'm hearing is workforce planning, but you know that there has to be something more than that.
There's a number of subtleties in the different ways of asking the same question. I suppose if I try and answer it from my perspective as to what I think the issue is, if what we're saying is, do we need to be assured, all of us, you as elected representatives and colleagues and I in our respective day jobs, all assured that what I am commissioning from the public sector, from trusts and then from within trusts, ultimately from individual consultants, that's what we actually get? Yes, clearly we do. That's why we have the transparency that we have, all the way down to how many diagnostic tests, how many outpatient appointments, how many review appointments, and so on and so forth. That was built up from the bottom up based on the number of consultants that are there, how many sessions they have, and so on and so forth. Notwithstanding having that transparency and clarity, I flagged up some of the limitations with that approach, that it's a bit operational, a bit transactional, and actually doesn't necessarily motivate consultants to get out of bed in the morning, bluntly. If we're not careful, all we collectively do is to turn their job into a series of individual patient episodes as opposed to a more holistic caring for a wider population and group of patients. So that's been the approach on that side of things. In terms of the getting more capacity into the system and avoiding consultants on being a tension conflict between the private sector, public sector. We have sought through our commissioning of independent sector capacity to make as much use as possible within procurement rules of capacity from outside Northern Ireland, be it capacity from the Republic or be it capacity from GB, simply to try and draw in more capacity reflecting the challenge that you're putting on the table, which is we're just cycling the same work around the same group of staff. So to try and bring genuine additionality to the system, and we've actively been pursuing that as a strategy.
But with respect in as well, I mean, one of the things that we were, I suppose, becoming aware of was just the cost of the private sector, both here in the north and across the island and in England, was much more expensive in terms of use of private sector. And some of the experts indicated to us that, civil servants, with respect, are not trained negotiators in terms of achieving good deals with private providers. So how do you address that?
If I try and address that, I suppose the starting point has to be in a position where demand exceeds capacity. Fact, demand exceeds capacity. We have a choice. Either A, we can have longer waiting times than we do, or B, we can secure additional capacity from another provider. The only other provider that is readily, straightforwardly accessible for us is the independent sector. So first order things, we need to get past that in terms of, I'm happy to have a separate discussion about why there's any capacity gap and what we might do about that.
No, I don't think that's the question that's been raised.
No, I realise that I was going to get...
The question that's been raised is what can the department and the board do in relation to dealing with that conflict?
Second order thing then around the value for money from the independent sector. We have a framework contract, and no company can be on that framework contract unless they are committed to delivering services for the English tariff. Civil servants, equally as able as my colleagues sitting beside me, have across the water, drawing on lots of procurement expertise, agreed over a long period of time through a very robust process what a reasonable price is to pay for individual procedures. We don't try and reinvent that wheel, Chair, locally. We simply use that. So the orthopaedics tender that's out at the minute, we have, whilst providers are free to bid at whatever price that they wish to that orthopaedics tender, from our perspective, clearly we have as a frame of reference what would be a reasonable price to pay consistent with the tariff. So I believe for providing, and for as long as we secure prices from the independent sector that are at or below tariff, and generally we have been successful in doing so. But I did mention in response to a previous question that we have had some challenges in some specialties doing that of late. Then I believe we are securing value for money from the use of the IS. A separate question is, could better value for money be secured from delivering the services within the public sector? Perhaps, probably, but that's a separate question given that where we started the discussion from. Okay,
there was a number of people just on this. I think Roy had indicated first, and then Fergal. And
just to reinforce the issue that I think in order to get value for money, you should be at least testing what local clinicians and local teams of nurses and allied professionals can provide the service for. I mean, I have heard criticism of some of the work that is subcontracted, because it doesn't have the same level of follow-up that's possible when locals carry it out. So we're just seeking confirmation that you are open to enabling teams to do that and build and improve their existing teams for the long term.
Absolutely. Absolutely. And I did say again, in terms of how do we respond to gaps that are around, the first thing that we do is to seek from the in-house team, can you, as a non-recurrent, one-off initiative, do something more? I've highlighted myself, though, holding the mirror up to the approach that we have. Is there more that we can do even than that, though, to energise those teams, unencumbered by such bureaucratic, limited thinking that we may be directly or indirectly imposing on them? Untethered from all of that, show us what you can do. And if you can demonstrate to me that following all demonstration of good practice that we would expect to see at outpatients and one-stop shops and access to diagnostic tests and so on and so forth, that there's a resource bill at the end of that, but that in return for that we receive significantly greater throughput than is currently the case, then we are all ears. So yes, absolutely, Mr. Bex.
But just to try to delve into that a wee bit further, given that the private sector exists and the public sector exists, what would be the motivation for somebody to squeeze more out of the public sector in terms of productivity, if the private sector is there to pay some of those people to do it elsewhere? So what would be the motivation?
Well, I think you could have a separate discussions with some clinical teams, and that would be helpful for you to reassure you actually as to how committed those teams are to trying to do the best thing within the public sector. I think there's always exceptions, but for the vast majority of clinicians, they want to do the best for patients within the public sector. They think they can do that and do some private sector work at the margins, rather than the two things being in conflict, as the Chair referred to earlier on.
Do you routinely then measure the extent to which public service contracts or consultants or whatever do the work in the private sector? Are you aware of the scale of that? Do you get a feedback on person X works X hours there, and then whenever they do work in the private, do you know that?
I wouldn't know that individually, but what I mentioned to you earlier...
Does the system know that?
An individual trust would know that, because there's a set of rules in terms of what a consultant must deliver before he or she is able to work in the private sector.
But do you then know the scale of the work they've done in the private sector?
We know that they are currently, we're paying about 6% of elective spend.
No,
on
that's the total.
sector. Yeah.
But do you know that, right, Surgeon X is working in the public sector and he's contracted for X days a week and X operations? Do you know how many operations that individual is doing routinely in the private sector?
At an individual consultant level, I don't think we would know that. That would be the trust would know clearly what work that individual is undertaking within the public sector contract. The individual's employer in the private sector would know how much work they're doing in the private sector. The individual is accountable for ensuring that their working hours do not exceed the working time directive, which is the sum of both of those. But to an extent, they are separate from each other.
Given the issue that we're talking about here in terms of waiting times, is that not valuable information?
What would we do with that if we had it, Mr. McKinney? If say I was a consultant, I do 11 PAs within the public sector, and say I do 3 PAs equivalent, half-day equivalents within the private sector. I'm not quite sure what
But we don't know.
But I'm not sure what I would do with it if I did know, or even whether it would be within my gift to...
Given that we're spending millions in the private sector, it might encourage us to think differently about how we do our work and how we negotiate with consultants overall. But we don't know the information, so we can't make a judgment.
The trust know the information. The trust know the information in relation to
the department?
We can ask the trust for information.
No, so this brings me back to the responsibility thing.
We know we don't have that level of detail.
But you don't have it, Dean, and you don't have it.
But also,
who's responsible?
Not all of the work that consultants do in the private sector is paid for by the public sector. Some of it is fully private.
Right. That's true too, and given the conflict that we've talked about notionally here, would it not be valuable to have it? So I raise it. It underscores for me the issue of the responsibility that we've talked about in terms of at departmental level or bang up against ministers.
But if I might challenge you, Mr. McKinney, just to come back, I'm just trying, because genuinely, I found a lot of discussion today very helpful in terms of just ideas that we'll take away. I'm trying to work out what I would do with that. So just to use the example that we've said there, say it was one of the providers we use a lot is 352 within Belfast. So if I did know that consultant X, a surgeon, is doing his or her 11 sessions within the public sector, within Belfast Trust, say, I know what that needs to look like because I've got numbers that tell me how that adds up for him and for her and for the team and so on. And I know I'm getting that, or know if I'm not getting that. So I know that already. Equally, if I was commissioning from 352, I know what I'm meant to get from them as well as an organisation that I'm commissioning from. I'm trying to work out if I knew for an individual consultant who happened to be working in both bits of the system, and as Chris is saying, that maybe some of the work he's doing in 352 as a particular provider could be pure private sector work, and some could be funded by the... I'll reflect on. I'm not sure what I would do with that if I had it.
But would that information not also give you an insight into an individual having an appetite to work in that field, and therefore can that person not be given the additional hours in terms of
that? I think it does go back
to public sector.
And I think it goes back, and it goes back to your point about squeezing that extra bit out of the public sector and getting teams to imagine how they would work differently.
I could see I think that's right. I could see how that potentially, because there are consultants who, for a whole combination of reasons, don't want to do anything beyond their 10 PAs. It certainly would give a flavour of those consultants for whom 13, 14 PAs in total is the sort of working arrangement that they would like to have. I would come back again, though, to the approach that I talked about, which is the unencumbered by all the bureaucracy and so on. As a team of surgeons, urologists, whatever, tell us how you might deliver things differently for us and see whether that motivates them in a different way rather than the way we have been commissioned.
I think even your last response there indicates that you would see value in the information I'm talking about.
I'm not sure that I necessarily would, because I am bearing in mind what that discussion looks like. So say, there's a team of 4 urologists at the top of the table, for example, 5 urologists at the top of the table. I am passing the challenge across to you, come forward with something radical for me. The risk for the process that I've described earlier on of doing what you're describing is I'm getting back into my bad old ways about wanting to second guess everything. And what you should be saying to me as a team urologist is, Dean, get off the pitch. Let us get on with this. We will come forward with a radical solution. The more we micromanage and more we operationalise things, the greater is the risk of us getting what we've always got, because that has been the approach to date. We know everything that moves in unscheduled care and elective care by trust, by site, within trust, and all the rest of it. And I'm suggesting, hypothesising, that a different approach, a more hands-off approach, might be helpful with key information, and I'll reflect on that, and maybe it's in there that might be helpful either for me or for trusts, but primarily trying to empower clinicians rather than second-guess them.
If I just might add to that point, I think one example where we have seen that happening successfully recently was in New Zealand and Canterbury. It came about for a particular reason. There had to be a fundamental change in the way care that was delivered because the earthquake knocked down a lot of the buildings. So there was a sudden disruptive need for change. The analysis of that's been done by the King's Fund and others, I think, points to the very fact that Dean is emphasising. The changes were clinically led. It wasn't characterised by a targets and terror regime. There was, of course, robust monitoring of performance. There still is. But primarily the change in the pattern of services and the way services are delivered was led by the clinicians and is seen as having been very successful because of that. And there is now effective management of waiting lists and waiting times in Canterbury.
Let's hope it doesn't take an earthquake.
Okay, Mickey, on
Beyond our party arrays.
Just to make a comment, and I don't expect you to comment upon what I'm saying, but it just seems to me around the whole issue of privatisation, there is, and it's predicated on the perception abroad that the current British government is intent, if not already involved, in dismantling the welfare state as we know it. Now, there's no doubt that that would have a knock-on effect. And, I would be not necessarily of that opinion at the moment, but there is a notion abroad that that is the process that is happening. And when you look at transforming your care, what it could become, that reinforces in some cases that notion. But I wouldn't expect you to comment on that necessarily.
I think any civil servant should always be very hesitant before putting themselves in the place of the Minister, but I think if the Minister were here, he would say very clearly he has no agenda for privatisation, and that is not what TYC is about.
But I think the point I was making with respect is the Minister is not a member of the British government, but it will have a knock-on effect, possibly. That's really the point.
But he is British.
Okay.
But he is British.
Folks, can I thank you for your presentation. I think it has been useful exchange. It probably leaves us with a number of questions. Going forward, obviously the committee are about to go into a process of making recommendations, but I think specifically the key messages that I took from this was the shift in terms of the referral to treatment time, and I'm not sure, we haven't been given a sense of what a realistic time frame for that might be. We would look forward to getting that clarification from yourselves. I think also the issue of the enforcement of targets, the clear whose responsibility is it in terms of enforcement, and what are the policies around incentives, or the development policies around incentives. I think equally a huge issue there has been the management of this piece of work, where it should sit, does it need another team, is there a lead body, is that strong enough, what has been the lessons from the 2004-5 processes moving forward. And I think also the issue of the private sector involvement in relation to the investment that is there and how that can be used to assist, support, enhance workforce within the health service, and equally how we can use that information to ensure that the conflict that is there between public and private in some occasions is eradicated. So, with those couple of points, we'll continue to have those conversations, but I thank you very much for your time today.
Thank you.
Okay, members, moving on to item 5 is a statutory rule, which is the Firefighters Pension Scheme. It's on page 91. The purpose of the rule is to align with similar changes that have been introduced to firefighters' pensions in England. Can I ask our members intent to proceed?
Great.
Thank you. Item 6 is another statutory rule, the new Firefighters Pension Scheme Amendment number 2. It's on page 96. And again, the purpose of that is to align with similar changes that have been introduced in England. Are members content to proceed?
Great.
Item 7 is the Misuse of Drugs Amendment number 2 and Misuse of Drugs Safe Custody Amendment. I'm referring members to page 41 of the tabled papers. The purpose of this proposed statutory rule is to control the use of various drugs, such as tramadol and compounds that have been sold as legal highs. The regulations are also being made in England, Scotland and Wales. Are members content to proceed with the statutory rule?
Agreed.
Item 8 is the Misuse of Drugs Designation Amendment number 2, and it's 49 of the tabled papers. The purpose of this rule is related to the previous one we've just discussed. It will designate various drugs such as tramadol and compounds that have been sold as legal highs, and these regulations are also being made in England, Scotland and Wales. So are members content to proceed?
Great.
Item 9 is the Forward Work Programme. I'm asking members to note that, which is on page 101. Item 10 are matters arising. Asking members to note item 8.1 on page 104. Informing members that minor amendments have been made to the SR 2014-126, the Draft Council of the Pharmaceutical Society, at the request of the Examiner of Statutory Rules. The amendments do not change the purpose or operation of the statutory rule, and this rule was considered approved by the committee at its meeting on the 14th of May 2014. So I'm asking our members content to note.
Great.
Thank you. I'm referring members to correspondence from the Minister regarding his intention to introduce the Food Hygiene Rating Bill, which is at page 3 of your tabled papers. The Minister has said that he intended to introduce the bill before the summer recess, and therefore committee stage would be expected to begin sometime in September. I would say this will be a significant piece of work for the committee next session, and the Minister has provided an in-confidence copy of the bill at this stage for members' information. Members will recall that the committee received a briefing on the proposed bill from the Food Standards Agency in February 2012. So are members content to note that for the meantime?
Great.
Referring members to a response from the Minister regarding the June monitoring round, which is on the tables as a separate sheet. The committee had queried the classification of the Transforming Your Care bid as Category C. The Minister is making the point that DFP required classification of bids, but that does not necessarily reflect the Department's priorities. The Minister also states that TYC project is still on track, although the funding for implementation may slip from a 3-year to a 5-year period. And in relation to the surrender of money for the Children's Hospital, the Minister states that this does not put the project at risk. Can I suggest, by way of comment, that the issue of classification of the Department's priorities is something that should be really shared with the committee. We did have correspondence at last week's meeting indicating that there was a priority list. This correspondence is now saying that that is making the point that DFP require classification, but it doesn't necessarily reflect the Department's priorities. I think it would be appropriate that the committee sought clarification on what the Department's priorities actually were. And I think it's also worth noting that the surrender of the, I think, 10.4 million for the Children's Hospital, the Minister stating it doesn't put the project at risk, but again, it doesn't answer why this happened in the first place, and I think we should seek clarification on that. Members agreed?
Agreed.
Thank you. Item 11 is correspondence. I'm asking members to note 9.1 on page 114. Item 9.2 on page 119 is correspondence from West Tyrone against wind turbines. And the Environment Committee is currently dealing with the issue and is actually carrying out an inquiry, and it's already in touch with the group. So I suggest that the committee therefore just notes this correspondence.
Great.
I agree with you entirely. Just maybe would it be helpful just to find out if part of that inquiry is around health implications, because I'm not sure that it is, to be honest. So we just get some clarity on
Okay.
that. But
Okay.
I agree
Yeah.
it sits well with
Happy to
environment.
do that. Yeah, sure.
Thank
you. Just at this point, I want to inform members that we're now going to deal with agenda item 12, and it'll take place in closed session, as we agreed at last week's meeting. We're hoping, time allowing, that it should last about 30-40 minutes. The committee will then move back into open session for the evidence session on payroll issues affecting health and social care staff. Today at page 33 of the tabled items. Folks, you're very welcome. We have Julie Thompson, Deputy Secretary, Resources and Performance Management, Mr David Bingham, Chief Executive Business Service Organisation, and Mr Eamon Malloy, HR Director, South Eastern Health and Social Care Trust. You're very welcome. Obviously a hugely important issue for us all collectively, so if I could just ask you, Julie, I think, are you leading on this? 10-minute presentation, we'll open it up to members' comments.
Okay. Thank you for the opportunity to provide evidence to the committee today on the recent payroll issues that have been experienced by HSC staff. As the committee will be aware, all HSC trusts have introduced a new Human Resources Payroll, Travel and Subsistence System, HRPTS, over the last year. The Business Services Organisation currently provides payroll shared services for the Belfast Trust and the Western Trust and the regional organisations, and the remaining trusts then currently provide their own payroll services until they transition to shared services over the next few months. Whilst the vast majority of payments to HSC staff have been made correctly over this period, unfortunately there have been problems for some staff, and we are working hard to address these difficulties. These issues can be considered under three key categories. Firstly, there have been issues regarding the receipt of enhancements such as overtime and payments for unsociable hours. The payment of basic pay has been largely unaffected. Secondly, there was a system issue which emerged at the start of the new tax year, which meant that a number of staff had additional national insurance contributions deducted from their pay in error. And thirdly, emergency tax codes were incorrectly applied in the April pay run to a significant number of staff that have multiple employment contracts with the HSC. And I'll go through each of those in a moment. The Minister has recently highlighted his concern to the Assembly about these difficulties. He has a clear expectation that departmental officials and Trust and BSO management will work collectively to ensure that all outstanding payments are made quickly, and that, on a case-by-case basis, there is urgent consideration given to any losses experienced by staff arising from employer responsibilities. I can assure the committee that we are all committed to ensuring that staff receive the correct pay. This requires individual staff, managers, payroll departments and the payroll system supplier working together to follow the correct procedures and processes and learn the lessons when mistakes are made. Then looking at each of the issues in turn and updating the committee on where things are at currently. In terms of addressing the issues involving the enhancements to basic pay, it is important to note that the new payroll system puts an emphasis on employees and managers submitting claims for additional payments in a timely and appropriate way. The BSO and Trust continue to re-emphasise the importance of adhering to these protocols. There's also ongoing training and awareness work with managers who complete and submit timesheets. The BSO and Trusts have already implemented a range of measures. This includes running additional payment cycles to make good any underpayments, and where this has not addressed the problem, for example in cases of hardship, then emergency payments have also been used. In addition to this, we have approved further expert support for the HSE payroll functions over the coming months. This will provide additional resource to help with the familiarisation with the new system and will also help staff develop solutions to queries. Looking forward, a range of continuous improvement measures will also be introduced to stabilise and enhance services. This will include the consideration of moving all staff to monthly payroll cycles to improve efficiency and also reduce the opportunity for error. The second issue is to do with NIC. HSE organisations have worked closely with the system supplier to identify those employees affected by incorrect national insurance contributions, and outstanding payments have been made to each member of staff. A corrective fix to the system has been applied to prevent this issue reoccurring, and as such this issue has been resolved. In terms of the application of emergency tax codes, the HMRC has reviewed the tax codes for all affected staff and, where appropriate, revised the tax codes in time for the May pay run. The HMRC has confirmed that some staff still remain on an emergency tax code in line with their normal business, and these are being considered on a case-by-case basis. Finally, the importance of communication has been recognised, and steps have been taken to increase the level of payroll helpline support to deal with queries and to communicate to staff and trade union side the progress on each of these issues and the implications for employees' pay slips. I would also wish to pay credit to the staff in the payroll departments in the BSO and the trusts for all their hard work and commitment, particularly in recent weeks, to sort out the issues and ensure staff receive the correct pay. In closing, we accept that there have been problems with the introduction of the new payroll system and that further improvements must be made. This is a complex pay system for 70,000 staff, but each member of staff has the right to receive their correct pay, and we must all work together to make the necessary improvements. Thank you for this opportunity, and I'd be happy to take questions on any of the issues that has been raised. And I think, as you say, you've also got correspondence from the department in recent days as well.
Okay, thank you, Julie. Firstly, just I suppose to clarify that the Minister's response on the 28th of May separated out the issues, talked about the NIC payments, and as you reiterated there, said there's been a corrective fix to the system applied. So is that the assurance that in terms of NIC payments that all of that has been resolved?
Yes, payments have been made to staff to correct the overpayment, and the corrective fix has been applied to the system to prevent that reoccurring.
So we will not, going forward, see any issues in relation to NIC
That's our current understanding, absolutely.
There will be no issues, okay. So the second issue was the tax codes, and in some cases the incorrect tax codes, emergency tax codes, etc. And what the Minister has indicated here was HMRC has reviewed the tax codes for all affected staff, in brackets, except some 16 staff at this stage, and where appropriate have revised the tax codes in time for the May pay run. So can we maybe clarify that?
Okay.
You know, on two fronts, what do we mean reviewed, and what have we done to resolve? And second of all, what is the 16 staff? Why is there 16 staff that haven't been reviewed?
Okay, in terms of the 16 staff, they were particularly complex cases, as I understand it, from the HMRC. This is work the HMRC had to do in order to look at the tax codes and ensure that they applied the right ones to the staff. As an employer, we cannot apply tax codes that comes from the HMRC. So they had, at the time of that letter, those were 16 particularly complex cases that they had yet to review at that stage. In terms of, as the letter pointed out, as I said earlier, that does not mean to say that there aren't any staff with emergency tax codes. There are still some people in that position. That is a normal piece of business, and maybe Eamon can comment a bit more on this. So at any one point in time, there will always be people, an element of staff on emergency tax codes, and the HMRC work with those people on an individual basis to deal with the issues and to move them onto the appropriate code as they get clearer on facts. So as we see it, the significant numbers of staff that were experiencing the problems in April have been addressed. Some 5,000 staff had a change to their tax code applied in May, and now HMRC are effectively dealing with individual cases on a case-by-case basis. But at any one point in time, you will always have some element of staff on emergency tax codes. Is there anything you want to add to that?
That would be the case. I think the added complication here was really in respect of individuals who are members of staff who hold what are called multiple contracts. So they may have a primary employment contract with us for their primary employment, but also work as part of our nurse bank, and on occasions we'd receive a contract for that. The treatment of that became tricky at the end of the tax year and moving into the new tax year, and as I understand it, that was the primary reason for the difficulties around the tax code issue. But at the end and start of a tax year, we would always have staff who would have a change in circumstances. HMRC would recalculate their tax and indeed their tax code in respect of that. So there will always be a certain amount, Chair, that would have an emergency tax code for a period of time. Associated with this issue, we now know that the numbers are small. They're in the tens, they're not in the hundreds, in respect of those individuals who still remain on emergency tax code as a consequence of the multiple contract piece.
But, you know, with respect, even 10's too many. When you know you're dealing with the day-to-day role that a number of these staff deliver in terms of our health service, and people struggling. So, you know, one's too many. So we're saying, and I accept that there can be flexibilities in systems. But how do you, first of all, give us the assurance that the system now going forward is guaranteed to be foolproof in terms of these things not happening again? And secondly, how will the department, I suppose in particular, deal with the very real threat from large sections of the workforce through their trade unions that they may consider industrial action?
In terms of the tax code issue, certainly we've reached a point whereby it's normal business for HMRC to continue to work with the staff on an ongoing basis. I appreciate that may create difficulties for those individual members of staff, but HMRC have taken it through. They've looked at all the affected staff and they've fixed over 5,000 tax codes going into the month of May. That was all done in a very short space of time and took a focused effort both on our side and on their side to ensure that everybody had the right information to enable that to happen. So in terms of then dealing with those that remain on emergency tax codes, they will be worked through on an individual basis. We can't help an awful lot with that. There's literally a conversation that needs to happen between the individual and the Inland Revenue. We did a lot of work centrally with them because of the issue was common effectively across all our employees, but we've now reached a point where that conversation will have to happen between HMRC and the individuals, and they work through that as an ongoing piece of work, and they would do right the way through and would have done in the past, in the old system, in the new system, and will continue to happen. So I can't guarantee that there will never be anybody in emergency tax codes. That applies right across the board, wherever we work, and that's just the way things go with the HMRC. So that unfortunately is where that particular.
What about the issue about staff?
In terms of the workforce issues, obviously we are working very closely with the trade union side and have done throughout this piece to ensure both that they understand where we're at in resolving issues, and we've also worked around, for example, whenever there was concerns about the transition for Belfast Trust into the Shared Services Centre, that we would put mitigating steps effectively in place around that, which was working with the trade union side to try and address some of their concerns. So we're keeping them up to speed. We're liaising with staff, both through them and directly. And one of the other concerns that was raised a lot was about communication and people not able to get through to payroll departments, and more resources have gone into that. At the very start of this, it was quite complex because the people who were answering the telephone lines also needed to fix the payments. We've worked our way through that, and there's extra resources now in place within payroll departments. So we are responding and working with the unions to deal with their concerns, and to ensure that we move things on, that they're clear where we've got to in that approach.
And finally, should we not have seen this coming?
In terms of, I guess, when you implement any payroll system, there are going to be difficulties and issues as you change from one set of processes to another. And certainly the timesheet issue in terms of the enhancements and the basic pay, those are the issues that we're dealing with now, which need to be resolved and managed out and reduced as we go forward. And those are what you would expect, I guess, as normal issues as you implement a system. That does not make it any easier for anybody who has been affected by it. The NIC issue was an unexpected one to us. That certainly was not expected. We worked very quickly to get that sorted. The pay went into people's bank accounts 1 week later, and the fix was applied to prevent it reoccurring. And the HMRC issue was coming effectively from what had happened on the HMRC side. So each of them is being dealt with and progressed along the journey. But I don't think it would be fair to say you could implement such a complex payroll system and not experience some level of difficulty. Having said that, we need to improve, and we know we need to improve in order to make it better for staff, and that's what we're committed to do.
Okay, there's a number of members. Fergal first.
Thank you, Chair. Thank you, Chair. And while we're discussing this, obviously, at a strategic level, it's clear, as has already been expressed, that clearly this is causing enormous anxiety for staff and unions on a collective basis. And individuals in terms of very stressed circumstances and not getting paid. But could I just look to the scale of the problem and how much money was not paid out and how many people did it affect?
In terms of for example, the level of the NIC problem is around about 7,000 staff affected there. I don't have the quantities in terms of the amounts.
Average £107 per person.
That's just the NIC problem.
The NIC problem.
On the overall, no, in total, how much money wasn't paid out?
I don't have that analysis. I know the 7,000 and the NIC average 107. We know there was 5,000 emergency tax codes that needed to be changed into May. We can look to see if we can get that for you, Fergal. I certainly don't have it with me today. What we have done is implemented a range of all-cycle pay runs, and it would be relatively straightforward, I think, to establish the level of money going through those.
Would you have a guesstimate?
I don't have it today, no. I know the numbers of staff, not the quantity, because each person obviously is affected differently.
It would have been helpful to have that figure. Do you know today how much is still outstanding?
Essentially, almost everyone who was... you're back to the three causes of the problem. National insurance, people got the money.
No, I understand, and we've had a very good explanation about that and the work that you're doing, but do you have today an assessment of the money still outstanding?
I don't have a figure today, but we can tell you because most people got the money they were owed within 3 days. So we can go back and get that amount. I'm sure it will run into several £million, but it was in people's bank accounts normally within 3 days, sometimes 5 working days.
I mean, obviously I've talked about it at a strategic level, but clearly all our offices are getting inundated with calls from people who still substantially after the period are not receiving figures in excess of £1,000. That's what we're hearing. Is that still the case?
We are not hearing of those amounts in those large numbers.
And in terms of, then that's in terms of...
In the last week, for instance.
That's over and above wages. I'm talking about reimbursements here.
Certainly the level of difficulty being experienced was very high in the month of April whenever the NIC issue hit and the tax code issue hit. In terms of the scale of the problems, since then they have been at a lower level, but that doesn't mean that the staff are affected. Obviously, it is a significant issue for them. Because what is happening within payroll departments is that any underpayments are being addressed very quickly. So it is a very, very fluid situation. So even if we answered that question today, the level of outstanding today, if you like, would be different because they're being corrected on an ongoing basis. So I'm not sure, Eamon, do you have anything maybe can be added from the South East Trust perspective?
Certainly from our perspective, it would be really important for us to find that information out. If anyone is suffering financial detriment to that level, I would be extremely concerned, and we would make all efforts to get that payment back into their bank account as quickly as. But to be absolutely upfront and honest with you, I'm not hearing that level of disquiet, and believe me, I would hear it quite directly, not only from the individual members of staff, but from their trade unions. My phone would be red hot, I can guarantee you.
Obviously, this has been categorised as a software problem, but my understanding is that there were redundancies around payroll, and that part of the problem is staff not trained inputting or not fully aware of the new process, inputting data which gets lost on a screen. Is that true? Is that your understanding of what the problem is?
The only bit that is, I guess, is fully a software issue was the NIC problem. In terms of the enhancements issue and the dealing with processes, there's a lot of processes at play there, and a lot of, and this goes right across, right from the very start to the individual, to their managers, through to the payroll departments. That all needs to work seamlessly as a process in order for the right pay to go out at the other end. So absolutely, I would accept that there have been issues around people not being clear about procedures, and that we have put extra effort into training, into awareness, and looking at procedures on an ongoing basis at every step of that. So whether it be in the payroll departments locally within trusts or in the shared services centre, or then working with individual staff around what it means for them. But it does take all bits of that effectively to work in the new way.
It's a broad question, but whose fault was that?
Well, we did put in training measures, and if that has not been sufficient, we need to look at that. In terms of the overall governance of the piece, I'm sitting as Senior Responsible Officer. That's my role. I know I'm normally here in a finance position in front of you, but for this particular project, I'm Senior Responsible Officer for it. But we have a range of governance procedures which go through the regional level and then right down to within individual trusts. And all I would say to the question you've asked is that it takes every single bit of the system to work in the right way, and therefore we need to learn lessons if people are having difficulty with particular issues. We've also put additional support in to allow extra training to go in there, and are working, I think it would be fair to say, both within trusts and across the BSO to try and ensure that those particular issues are dealt with and people are trained effectively for the future.
Just for our assessment, it would be helpful to know how much money is still outstanding on that enhancement basis as well. And just one final question for me. Clearly, some people have been impacted of what we're hearing to such an extent that it may even have could potentially affect credit rating. Is there any system that you can put in place that gives guarantees to those that are, so that individuals can have some reassurance that their credit rating isn't negatively affected going forward?
If I could ask David to talk about that in a general sense, and maybe then even to give you a feel for what that looks like in a trust, maybe just to give the answer to that.
Yes, we have prepared a standard letter which employers can, so if an employee has that problem, they approach their line manager who will report to HR, and there's a standard letter that the trust can send to the bank or whatever financial organisation that sets out the background. So we have prepared for that, and that's available.
And very, very small numbers of individuals, less than one hand, have queried that with us on the basis, is the facility available, rather than I'm in difficulty with a credit reference agency. But again, as Julie and David has rightly said, that facility is there should anyone experience that. As I understand it, credit reference agencies would work on the basis of defaults over a period of months, rather than 1 month or 2 months or whatever. So I think from that perspective, that's probably why we're receiving low inquiries about it. But needless to say, the facility's there if any staff wish to use.
Thank you, Chair, for the time.
Mickey?
Yeah, thanks for the presentation. Obviously, a lot of the staff, or a number of them, are involved in stressful occupations anyhow, so I'm sure this hasn't helped them. But I attended a meeting that you were at, Julie, in Armagh about 3 years ago, whatever, when BSO were going to change the payrolls and staff and all that. And my memory is that staff expressed disquiet at what might happen because of a new system coming in. And I suppose that's what we're hearing now, to some degree. That was a self-fulfilling prophecy, maybe. But I remember when the Civil Service Social Security Agency went live in 1993 with computerisation, the head of department told me, there was a phrase he used, the EU's GIGO, garbage in, garbage out. So that seems to be part of the difficulty in the inputting of information. You mentioned about 5,000 staff having new tax codes, but that's presumably to do with the budget change in terms of personal allowance and that.
No, it was to do with the taking them off the emergency tax code, so that gives you a feel for, I guess, the scale of that particular
that's
issue.
Fine, because it's just, you will always get staff on emergency codes in any occupation, but most of them are aware because there's been major change of circumstances, they're moving to a new job or whatever, so they'll be aware, but in this case it seems that emergency codes were applied or continue to be applied, when maybe, and that's the responsibility of HMRC, because I do accept you as employers just implementing what you're told by HMRC, but there is a difficulty in the inputting of information, because the national insurance contribution should be straightforward, because that's a percentage of your income. But I'm not sure what the problem, because all the records for them are kept on mainframe computers in Newcastle on time. You just wonder how, because that seems to be an additional problem that needs to be resolved, because that could well reoccur again.
I guess that's why we've tried to block this into the three issues, because they are very much distinct. You're absolutely right in terms of the tax code issue. We're now at a position where it is the normal, if you like, emergency tax codes in play that you get on an ongoing basis, and that just need to be worked through between employee and HMRC. So that's where that one currently sits. The NIC issue was a system issue, if you like, in terms of changing in the tax year. We have addressed that by making good the underpayments, but equally we've also put in a fix to stop that happening again. Now, that won't happen again, obviously, until you get to a new tax year next year, but that fix has gone in already to stop that particular one reoccurring. And then to get to the third issue, which is about the inputting, and that's the area, I guess, where we are currently, and that's where our focus is at the moment, because the other two issues are substantively, effectively resolved, and our focus, therefore, both as managers right across the system, is about dealing with what's causing the inputting difficulties. Is it training issues? And if so, where is the difficulty lie, and how do we bring people into, they're doing things differently, and yes, absolutely, there was concerns by staff raised, which were twofold, both about new systems, but also about different locations and that sort of thing. They were both at play at that stage.
Systems were one of the issues.
They were, but I think part of the reality of that, though, Mickey, is that we had to replace this system. It was over 30 years old. It needed to be updated. At somewhere along the line, we would have to have done what we've done. Now, that does not help an individual who is experiencing difficulties, but we had to take steps to change, and we're now working hard to address the problems that we've got. But we had to do this change.
Do you have any redress with the system's supplier? Because if you have a system that is malfunctioning, which this one obviously is, you paid millions and millions of pounds to put in place. The same thing's happening in Britain with the IT system for universal credit and all that, where they've written off millions because it simply isn't working. I'm just wondering, do you have any redress with the system supplier?
Where we can prove that it's a system supplier issue, we will absolutely
Could end up in a Mexican standoff then?
Well, it's difficult. Let's just put it like that. And certainly, I don't want to discuss that any further here. If you can understand.
It's just a question. I'm just wondering if there was any redress in whatever form it might take, because obviously the paramount issue in this case is the staff and the trauma and stress that they've been put through. As I said, a lot of them are involved in important, stressful jobs, and as any health staff member is involved in, and this just has added a bigger burden to them, and I think it's just regretful, and obviously you are trying to address it, but it just seems if you have a system put in place that doesn't work, then there has to be some way of redressing and having some comeback on that.
Completely understand that.
Thank you.
Okay, thank you, Mickey. I have Roy next.
Again, thanks for coming along here today and trying to give an explanation of what's happened, but I still don't quite understand how 5,000 tax codes could be wrong. Yes, there's a new system, there's potential of things going wrong, but was that fault with the information that was supplied to HMRC, or was the fault with HMRC?
No, our understanding is our information was supplied correctly to HMRC.
Okay. And then there's problems with the national insurance, and you have said that it's been implemented in the Belfast Trust and the Western Trust. This new system.
Can I clarify? It's just that the new system is in all the trusts.
Okay.
When I talked about Belfast and West, they all put the new system in, and then they are transitioning into a shared services arrangement. Okay, so that's the distinction there. So at the moment, the BSO, which David is in charge of, is dealing with the payroll not only for his own organisation but also the payroll for Belfast and for Western Trust. And over the next few months, the other trusts will all go into that shared services centre. They're already all on the new system, and that's a gradual transition over the next few months to happen.
Okay. Are there lessons that I've learned in terms of piloting out of this?
In terms of, we certainly, I think would be fair to say, have learnt lessons around making sure we do thorough testing of things. And I think the other issue, which is related to where Fergal was raising the issue, is around training and the absolute importance of making sure that people are trained and know how to work their way through the system.
As I understand, the system started to be introduced from October onwards. And that's why I really find it quite strange to be hearing that there was still ongoing problems with inputting and overtime payments and those on unusual contracts. You know, why has it taken 6 months to resolve if there are system issues?
The transition, the introduction onto the new system has been a gradual thing as well, okay? And started in the trusts in September, and the last trust went on in February, just past. So we've been bringing, rolling out, effectively to use that phrase, to trusts on an ongoing basis across those months. Once that was complete, then we started the process of bringing them through into the shared services environment. And I guess in terms of the issues that are presenting, the scale and the level of them, completely in April effectively was taken to a different level because of the NIC and the HMRC issues. And we are working hard now to address those. I'm not sure, David, if you want to add anything further to that.
The system was actually introduced in January 2013 to the regional organisation, my own organisation, the PHA, the Health Board and other organisations. And we had a period of 3 or 4 months where, now there are a total of 2,500 people employed there as opposed to 70,000 in trusts, but we had a period where we were experiencing similar types of problems, but we got through that by about April time, and the system calmed down. But as Julie said, I think you have a rolling programme within trusts, and as each trust, and perhaps Eamon can talk about his experience in South Eastern Trust, but what really has disrupted that pattern of getting back to normality was the NIC, and when you're talking about over 7,000 people, 1 in 10 of our workforce having a significant deduction, which hit us. We were as surprised as they were.
There always will be some mistakes made in payroll, just human error made by whether an individual somewhere. But when do you think we will be over the system problems, whether that's role of supervisors, software faults? When do you see this having settled down into a normal system? How soon can people expect to have a much more reliable payroll?
That's a very difficult question to answer, I think. In terms of where we're at, what we want to see is that trend of improvement coming through. We are looking where the issues are presenting and ensuring we're dealing with those. At any one point in time, you're absolutely right, that we couldn't guarantee that you would, at any point have 70,000 people all completely paid right. There would always have been an element of payroll dispute, if I can call it that, even in the old system. But we need to bring it down to a lower level, and we're committed to doing that. What I guess the proof of the pudding of that will be, because May was so taken up with fixing the April position, we're only now in June working through what you might call a normal month, and I would want to see a normal month working through to see how quickly and how good we're getting. A lot of what happened in May was basically taking payroll staff a lot of energy to deal with the NIC and to deal with the tax issue, and therefore I'd want to see June running through, and would hope that that is in a much more stable position than we were in pre-April. Okay, so that's the journey we're on, and then it might be easier to give you an answer in terms of right how far away are we now to where we would want to be.
And do you feel is there adequate support for your payroll staff who have been in an invidious position where no doubt they've been getting irate other employees down the phone at them? So are you satisfied you're giving them enough support, because it's not their fault that they're doing their job?
It's been a bit difficult for everybody, you're absolutely right. There's been challenges in terms of those phone lines, and that's why the additional support has gone in on the phone lines, so that at least that element is providing additional support to those payroll departments so that they can concentrate on fixing the queries and addressing them. It would be wrong, though, to say that payroll departments are completely stable at this point in time. Part of that conversation is about what support do they need, what training do they need, and what more do we need to put in there, and I guess take a little bit of a breath back from the difficulties that we're experiencing in May and move it on.
Okay,
thank you. And I have Gordon.
Thanks, Chair. Thanks very much, folks. Just clarify again the numbers of people that are on the system now. You talked about the Belfast Trust and the Western Trust.
Every single employee is on the new system, all 70,000 odd.
They're all on it now?
They're all on the new system. The difference for Belfast and West is that they are being processed via effectively the BSO, and the others are being processed. So Eamon, for example, in South East is still processing their own payroll. That's the only distinction. Everybody is on the new system. They all went on gradually over effectively the period of last autumn, spring, winter. So.
And I just thought that about 7,000 had problems.
7,000 had problems on the NIC issue, and that created significant problems for staff. Those payments were corrected within 1 week of the problem being identified, and whilst that was obviously very, very, very concerning for staff at the time.
7,000?
7,000, absolutely. Were all
Were
corrected.
addressed within 1 week?
Were addressed within 1 week. The tax issue took a month to sort out because it required another month's pay run to be run through, and that affected 5,000. But I think it would be fair to say, if you are a member of staff, I think the other message we would like to give is that if there are members of staff experiencing difficulties, they need to speak to their line manager or to the payroll departments and get their queries resolved. We can only fix what we know about, if you like, and we really would encourage people, if they've got concerns, to work through and make sure that we can take the necessary steps to get them fixed. Having said that, we're also getting a lot of calls from people who understandably are not sure whether they're getting paid the right amount or not, and you can understand how that happens too. And we need to reassure staff and get confidence back in terms of what pay is there.
When you're saying they're fixed, but obviously people wouldn't have got the money, they're going to have to wait till the month. We can
do what's called off-cycle pay runs, and we are using those on an ongoing basis where a problem is identified. Those off-cycle payment runs are being applied very quickly, and pay is going in, 3-4 days after the issue has been identified. Okay. So that's why it's important that we understand where people are, particularly with some of the big numbers that have been talked about. We really want to understand who those people are and get them fixed.
The problem with the software, the system, obviously there was a transfer of data from one system to the other. Is that where the failure was?
Absolutely not. No. We spent months at trust level making sure that the data that was in our old legacy system was cleansed to the absolute nth degree, and we didn't transfer any data until it passed sufficient tests that the data was 100% clean. That's a fundamental piece of any information system data transfer, obviously, and we took a lot of time over that, Mr Dunn, to make absolutely sure that it was right, so that primarily we couldn't have any comeback on the basis of your data is not clean, therefore we're going to have errors. So we eliminated that very early on.
So the failure really was?
There's the failure
in the system.
The threefold failure, I guess. One in the system, which was the NIC. The HMRC issue coming from the tax codes there, and then the final issue, which is just across everybody, which is about the payment of enhancements and that's about us getting our processes in order. And that's what we need to fix now. That's the work that is ongoing now to get that sorted.
The system itself is a really good system. You know, and I know it's difficult to understand that, but when you think that the system that we currently have is over 30, you know, I'm unfortunately old enough to remember the introduction of the legacy system 30 odd years ago, 36.
Does it have an arm at the side of it?
It had a starting handle, yes, you're right.
Battery.
But you know that's what we're talking about. We're talking about old green screens that you know that wouldn't have enough power to run the first bit of a start process in a normal computer. So, as Judy rightfully says, it was well overdue. But it is a good system. It is, you know, we're getting through these issues, and the picture is an improving picture. So, the issue that we had in respect of enhancements and issues around that, they have largely been dealt with.
Well, was there a change there to the methods of how they're reported? Was that part of it? The people maybe didn't pick up on that, and there's always this issue of staff that are not available, they're not made aware because they're on the sick, because they work nights, because they work different hours, and so on and so forth. Those people maybe weren't informed, maybe weren't advised, maybe weren't trained.
Work would have been ongoing to ensure that people were trained and did know what to do. Absolutely, so I can assure you on that. I think the issue more is around the fact that where data is input incorrectly at whatever stage in the system, you will end up with a position that the wrong answer comes out the other end. And what we need to do is understand why that is happening and tighten controls, tighten the checks and balances. We're doing a lot more checks, a lot more running through to ensure that things are being corrected, you know, before they happen, if you like, making sure we understand where information is coming from and ensure that it's all flowing through correctly through the system. But there's a lot that involves almost every member of staff effectively working in the new way with us, and that's a challenge. There's no doubt it's a challenge.
So you are confident, and you can give us an assurance that the system is fit for purpose?
The system is fit for purpose.
Yeah.
What we need to do is get the processes and everybody working through to get the input in the right way.
On Mr. Brady's analogy of the GIGO, I think it is really important that those bits, and there are a lot of moving bits in a health service payroll, a lot of moving parts, that those bits that we have control over, particularly in respect of timesheets and making sure that timesheets are properly completed and filled in correctly and enhancements are filled in properly, that they're done in a very timely way. The system itself is very sensitive. So if it picks up an error, it'll spin that error back out to us very quickly so that we can rectify it and get it back in again. But we want to try and get to the stage where we eliminate that aspect. So the training that has gone on has been enormous, but it hasn't stopped there. So we've got a lot of work that's going on in the background on as errors arise or if issues arise, we have root cause. So people go through what actually happened there systematically, identify with the system supplier what was the primary cause of that and how do we fix it. So they're looking at end-to-end processes, how uploads work, how roster systems work, making sure that all of those things work seamlessly, as Julie said earlier on.
And put in place systems to ensure that you don't have recurrence.
Absolutely. Absolutely, and based very, very primarily on that, that we learn from the experience that we actually have.
Close it out, right? Thanks very much.
Okay, just one final thing. How can you reassure us that valuable nurses and staff who are supposed to be at frontline duties aren't now involved in other administrative work of this nature, which is holding up their frontline duties?
We appreciate that obviously staff have been, if they have had issues, they've been obviously trying to get through to payroll lines and that sort of thing, which is a distraction from them doing their job, and that has been difficult for them to do, particularly if they're on shifts. So first of all, the more we can get the pay right, the less we minimise those difficulties. We are looking at timesheets and how those can be done efficiently in the first place, and also that there's checks and balances in there to make sure that they are stopped early in the process rather than going through. There is a self-service element to this system around the likes of people being able to update their bank details and look at annual leave and that sort of thing. That's modern technology around how all systems effectively are moving. But we are very conscious, and we've actually run pilots within both Western Trust and Belfast Trust around what does it mean on the ward, what does it mean for people who are in frontline service, and if there are issues there, how do we deal with them? So we've actually put in some positive steps to understand that more. I wouldn't wouldn't say we've got all the answers to that yet, but we're certainly trying to understand that so that we make sure that what is put in place is manageable at the front line. Absolutely, it's very important that it is.
Mickey had a quick point.
Yeah, I'm just, I suppose, a general question. When you're investing in a system, is there much research or analysis done of how effective that system may be? Because there are lessons from the past. I previously mentioned when the DSD Social Security Agency went live, they went £55 million over budget and still didn't work. It was the biggest computerisation, I think, since the NASA space programme. And they didn't get it right. There are lessons to be learned. So I'm just wondering, is there much analysis or research done? I mean, do you look at one or two system supplier and then come up with the best solution to your particular need in that sense? You know, because
huge amount of effort put into the procurement and specifying what we required, and then putting that out to the marketplace and understanding where suppliers were in terms of meeting our requirement. That was a huge investment of time, and had to be, in order to make sure that the system we ultimately got is able to do the job that we needed to do in a very complex environment. So combining that with the experiences of, it's not just buying, it's also about learning about how you implement, and that has been ongoing as well.
But there's a huge investment of money as well.
Yeah,
yes, absolutely.
That's something obviously you do consider.
Okay, folks, thank you for that update. Obviously, it's something that the committee will be tracking and monitoring very carefully, and you know, we're taking the assurances that we're hearing today. I think there are clearly lessons, and there's been an awful lot of hardship for people in relation to this. So we will be watching, I suppose, the next steps very carefully. But thank you for taking the time and coming here in front of us.
Thank you.
Okay, members, any other business? Finally, date and time and place of next meeting is Wednesday the 11th of June, starting at 2 p.m. in room 29 in Parliament Building. Thank you.
Room 29.
Huh?
Room 29.